which is on hip and pelvic trauma. Currently, sir is a professor and head of orthopedics and chief at JP and Apex Trauma Center, All India Institute of Medical Sciences. Well, he's a past president, Indian Orthopaedic Association, and is running the only cadaveric bone bank in India at All India Institute of Medical Sciences. He has over 680 publications, and he has been invited for more than 750 guest lectures all over the world. He has delivered several orations. He has published 16 books on orthopedics and has authored 54 chapters in various textbooks of orthopedics. He has been awarded the BC Roy National Award for the year 2014 and has been member of several international task force and consensus groups. He is a reviewer of over 24 national and international journals. He has conducted several training programs on arthroplasty, trauma, osteoporosis, and has performed several live demonstrations in orthopedic surgeries in India and abroad. So, thank you very much, sir, for being with us today on this platform, and I welcome you along with your faculty. Thank you. Over to you, sir.
Hello. Good evening, everyone. Welcome to this another online edition of Boot Symposium, where our American faculty has kindly agreed to participate and enrich you with their experience. And I'm joined by my distinguished faculty from India, and we are expecting and hoping it to be a very fruitful and enriching experience for you. Let me start with the introduction to the program. This is track 5, the hip and pelvis trauma. And I'm Dr. Rajesh Malhotra. I'm the program director, and I'm joined by very eminent OTA faculty. Our speakers this evening are Dr. Paul Tornetta. He is the Chief and Chair Professor and Residency Program Director in the Department of Orthopedic Surgery, Boston University School of Medicine, and he is also Director of Orthopedic Trauma, Boston Medical Center from the Boston, Massachusetts, United States. The other speaker this evening is again a very prominent and well-known speaker, and you all know him, is Dr. Hassan Mir. Dr. Hassan Mir is the Professor and Program Director and of the Orthopedic Residency Program in University of South Florida and Orthopedic Trauma Research at Florida Orthopedic Institute. Welcome, Dr. Paul and Dr. Hassan. And then we have with us Dr. Vivek Trikha, who's my colleague and works in the Jayaprakash Narayan Apex Trauma Center in New Delhi. He is a well-known name in Indian trauma circuits, and also Dr. Vikas Agashe, who is the consultant orthopedic surgeon in the PD Hinduja Hospital, and he works at Dr. Agashe's maternity and surgical nursing home in Mumbai as well. This is the outline of the program. I'm sure you have it. So we are all set to start, and I think I'll request Dr. Paul Tornetta to start with the inaugural talk on how I treat the symphyseal injury. Dr. Paul.
All right. Well, thank you very much for having us again. It's really a pleasure to be here. I was asked to talk about symphyseal fixation, sort of how I do it. There are some disclosures you can find on the OTA app. So, these are high energy injuries. I think everyone will end up plating these, and then the question of whether to add any posterior fixation. And I strongly believe in compression for stability. So plate failure is fairly common. Hardware failure up to 75%. Revision surgery in the literature as high as 16%. So my talk will be generated about, how does this occur and what can we do to avoid it? This is one of the papers that Chip Rout and his group put out, looking at early failure. And one of the things to note is that until you get to about 1.5 centimeters in the front of the pelvis, even if you have failure and separation, it doesn't necessarily mean you have a revision that's necessary. So here's a patient that did not require revision. They also, as Dr. Mir has shown, there are some ways to decrease that anterior fixation failure. So this is a paper they did, looking at the addition of posterior screws to decrease anterior fixation. This is not something that I've done, and I'll show you sort of my way of dealing with it. And of course, there's a lot of discrepancy in the back, right? There's an APC2, an APC3, and there's probably an APC2.5. So if you look at this paper, what they showed was that these things start to fall off around 2 months. This is where you start to get the failure rate. So early on, they don't tend to fail. It does happen slowly over time, and that's probably just from some increased instability in the back. So it's very likely that some of these that were fixed with anterior fixation only may have been more close to an APC3 injury. So a little bit of lack of diagnosis at the beginning may lead to this. There are certainly some that are quite easily diagnosed as APC2s, some that are very simply APC3s. And then those ones in between are the ones that I think there's some advantages in some of these other tactics. Roy Moed also showed that using a locked plate in the front was probably not a bright idea. There's a little bit of micromotion that occurs in the front if you don't take the cartilage, and you probably need to allow for that to happen. This is some work I did with Dave Templeman with some of my and his residents to look at sort of how I manage things. So I'll give you sort of an example. This is a case I did, 27, 28 years ago. This lady was 25 years old, 16 months postpartum. She lived on a farm. She's a big woman, really very, very active. She gained 80 pounds over the course of time just from having a lot of pain. She couldn't ride her horses. She couldn't work, and really required to do that. She's a farm girl who did a tremendous amount of physical labor. And this is her on her sort of bilateral standing films. And then here you can see her on her left single leg stance film and her right single leg stance film. And you can very clearly see that there's some motion in the front of the symphysis here. These patients, I inject their symphysis. So I brought her to the operating room, injected the symphysis. She had literally complete relief. And she said if it was like that all the time, she'd be really happy. She had some mild pain in the back, and that didn't change, of course, with symphyseal injection. I don't tend to inject the back because I think once you solve the problem in the front, you solve the problem in the back. So she was indicated for a symphyseal fusion. And I show this to point out that this is sort of the predicate to how I treat most symphyses now. So this is a little different, right? Because here you can see an image. I took the cartilage from the symphysis, and then I did a dovetail cutout, and you can see, let's see if this should play. You can see the instability that occurs here, and that's not instability I created. That's instability that occurred. And you can see with that dovetail cutout, then I take a piece of iliac crest that's slightly larger than that, trim it down. You can see the absolute compression that occurs across the symphyseal bodies when you take the cartilage in this a little better than you can normally, because here I've gone ahead and denuded the anterior portion of the symphysis, which is not normally something that I do. And then we place that in and compress it in a very strong way, and then I double plate it. No posterior fixation, of course, because that's not really that unstable once you've fixed it. This is what it looks like, and you know there's now a bridge going across, so you don't see a symphysis anymore. And we denuded and grafted the front, and here you can see this is, I think, about 2 years out when she was healed, back to work, and completely comfortable. And a close-up of that shows that really did fuse. Now, that's not what I'm looking for all the time, but that principle of getting very good compression in the front is, I think, important. So the hypothesis I had, many years ago is that if you take the cartilage, you get greater friction in the front, and that gives you a more stable construct. Like everything we do in orthopedic trauma is if you get good compression of the bone, that's the most important thing for your construct, right? It's not a matter of gapping. And the idea here was to do this and see if we had fewer failures. So we did a study, myself and Dave Templeman, and we looked at the excision and as it related to hardware failure, alignment, and revision surgery. So this is a retrospective study. all type 2s and 3s. Dave Templeman was the other surgeon, and he treats these exactly like I do. Only anterior fixation for type 2s because we don't think you need it in the back. Anterior posterior fixation for type 3s. We both do a very simple rectus sparing approach and use 6-hole plates with 3 screws on each side. The only difference being that I took the cartilage and he didn't. So we compared about 50 cases of excision versus retention. You can see sort of what these things look like. When you take the cartilage, they get much tighter. And then we evaluated on radiographs the symphyseal spacing and then hardware failure and revision surgeries. So there were 66 type 2s, so those didn't have any posterior fixation, 30 type 3s that did. There was really no difference in the reduction of the anterior ring for the types 2s and 3s, so we really did group these things together. So preoperatively, there was no difference in the excision versus retention group in the superior or central portion of the symphysis in terms of their separation, very similar patient groups. Postoperatively, if you took the cartilage, which I did, we had about 4 millimeters less displacement in the front, which is about the thickness of the symphyseal cartilage, right? So we take the cartilage, we compress, we get down to basically almost no separation. And then interestingly, at union, we lost 1 millimeter or 2, as did the other, but you can see that there's still a difference at union. So this is just an example of a case. There's a dislocation with a pretty simple APC2, obviously, APC3, where you're compressing the front, we put screws in the back to support that. And you can see over time, this goes on to unite well. So when we looked at the hardware complications, there was loosening in only 16% of the excision and only 4% of the plates broke without any residual separation. So a combined incidence of only 20% of anything. And that counted even simple screw loosening. So any loosening counted. Whereas though in the retention group, and again, this is a very strict definition of any screw loosening. So it was 52%. And these were different. So here's just an example of one of the cases that loosened and displaced a little bit. We did find hardware complications didn't correlate with age or with ISS, so it didn't have to do with that. Reoperation in the excision group, 0 cases, and retention group, 4. Now, 2 of those were for hardware failures, 1 for sacral non-union. You might intimate that the sacral non-union is related to some instability in the front. And 1 was certainly unrelated with heterotopic ossification removal. But in a group of almost 50 patients, there were 2 failures that required revision. So what we found was that the cartilage excision was certainly statistically better in failure, in the ultimate reduction, and in decreasing revision surgery. And, here's sort of the general technique. This is a simple case, APC2. You can see the separation a little bit on both SI joints. I don't fix those. So this is just the simple approach. What I do is a midline incision. I do like a rectus splitting approach. So we take the external oblique fascia, leave that intact, find the linea, split the linea, and then you can put your finger underneath the rectus, protect the bladder, come all the way down. Now you see the foot to the right, head to the left. So there's the bladder, just showing that. And then once you protect the bladder, I'll typically place these very narrow homins underneath the rectus on both sides, then strip off the superior portion of the ramus. Then you can see that there's the symphyseal bodies, the sucker is in there. At that point, I use an osteotome just to scrape off the cartilage and then curette what's left, and then get good compression and keep the rectus aside. So we put the clamp in front of the rectus, not underneath the rectus, so they don't get torn. And this is an older case. You can see the reduction, and here's the symphyseal reduction. This is the plate going in. I have a pre-contoured plate that most people will use now. This is an older case, so it's just a standard 6-hole plate. I also make sure that I drill this at the side. So I drill eccentrically in order to further compress. I think it's important that when you put these in, you get good compression, and that helps me with my symphyseal compression. And then, placing a drain and then bringing the edge of the rectus fascia together, you get a really nice closure. So in summary, I like a rectus splitting approach to protect the bladder. I always take the symphyseal cartilage. I compress it as much as I possibly can. And I use posterior fixation only for type 3 injuries, as we've really pretty clearly established that it's unnecessary if you can adequately diagnose what a type 2 injury is. So in my opinion, symphyseal cartilage excision is really something that probably everybody ought to be moving to. We've had no anterior pain from that. The pain scores are exceedingly low. We looked at outcomes of these patients in a second study, and there's no real deficit from that. It decreases loosening and it decreases hardware failure. Thanks very much.
Thanks a lot, Paul. That was a great talk. I would now invite Dr. Hassan Mir for his talk on the role of examination and anesthesia for the APC and LC injuries. Dr. Mir.
All right. So good morning, and it's an honor to be here with you, and hopefully I'll stay on time and give you a few contradictory views to my esteemed colleague, Dr. Tornetta. So these are my disclosures, which are available through the Academy as well. And so I'm coming to you from Florida, specifically Tampa, which is the west coast of Florida on the Gulf of Mexico. And we, are close to beaches and entertainment in Orlando. And so our hospital here is a 1,000 bed facility. We're the only level 1 trauma center on the west coast of Florida. And I'm with a large private practice group in Florida that also runs the university program for the residency training, as well as multiple fellowships. So I, invite any of you, once we're hopefully through this pandemic one day, to please come spend time with me at our center. So we've all seen these patients with minimally displaced pelvic ring injuries. And, early in my training about 15, 20 years ago, we would have trouble figuring out which ones of these would then go on to bad malunions with horrific pain, and how could we prevent this from happening? Because once this occurs, it's a very difficult issue to deal with. Similarly, as Dr. Tornetta showed, we have patients that we would fix in the front, and then they'd have hardware failure. And they may not always require revision, but they may not always be asymptomatic, and sometimes do actually hurt and have some discomfort. And it may just be a 3 or a 4 out of 10 on the visual analog scale, but if it's preventable, why would we not try to prevent it? And then, another example of a more displaced pelvic ring injury that underwent fixation, but just with screws placed in various spots and without really a guide to when you should fix around the ring, and how to prevent late deformity and malunion. So pelvic stability is been defined in different ways, but basically you want the pelvis to heal without deforming during the period of union. And there's various classification schemes that everyone is probably familiar with. If you do pelvic trauma, it's either based on the anatomy of the injury, the direction of impact to the pelvis, or the stability of the pelvic ring. So with the OTA classification, you really have those injuries that are completely stable and there's no disagreement on those. You have those that are completely unstable and blown apart, and you're going to fix everything. And then the argument and discussion comes in the middle when you have these type 2 injuries of the APC, or the lateral compression with a complete sacral injury and multiple ramus fractures. What do you do with those, and how do you fix them? So a lot of these classifications, though, are based on static imaging. And when you have pelvic binders or sheets, even without a binder or sheet, there's significant recoil to the pelvis. What you're seeing on your plain films or CT scan is not how badly the pelvis was deformed at the time of impact, and that's been shown. So first, we'll discuss APC injuries. So this was historically based on cadaveric video studies by Dr. Tile, and the number that came out of those cadaveric studies was 2.5 centimeters. However, in follow-up studies by other groups, it's been shown that the pelvic floor can be disrupted at a range of diastasis of the symphysis. So 2.5 may not be the most accurate number to always hang your hat on, especially on static imaging, maybe more so on dynamic imaging, because you really see that the pelvic floor is not imaged. So maybe we should get MRI. This was another group that looked at that, and showed that APC type 2 injuries can have a variety of injury to the pelvic floor and also attenuation of the posterior SI ligaments. But it's really difficult to get MRI scans on polytraumatized patients, as most of our pelvic ring injuries have multiple other issues. So some questions remain: which of our APC type 1s are actually masquerading and are truly APC2s, and then which APC2s have multiplanar instability? So this, my mentor during fellowship was Dr. Saji, who taught us the technique of examination under anesthesia, and this is his initial work, where you get 5 views in each plane on your AP, your inlet, and your outlet. So you have a static view without any examination. Then you have a hard internal stress, a hard external stress, push and pull to imitate single leg stance. And one of the questions that comes up is, how hard do you push? You push as hard as you can because you really want to try to mimic forces beyond what the patient may see after they're awake and mobilizing. So in the initial series, we found that 50% of the APC ones were actually unstable and had more than 2.5 centimeters of horizontal rotation or a centimeter of vertical translation, and that nearly 40% of the APC2s had multiplanar instability. So this was another group out of Denver that repeated and did a similar study. That's a U.S. quarter, which is a 25-cent piece that also happens to be 25 millimeters placed on the patient to help gauge the amount of displacement. And this is a case example from their series that shows a patient with instability on exam under anesthesia. And they found about a third of their patients in their series had occult instability. So this is a case example of mine where, it doesn't look too bad on the plain film or the CT scan. So we took the patient. No one would give me a coin when I told them where I was going to put it. So I had to use a ruler. And this patient didn't move more than 2 centimeters. So, this is the argument against those who say that every patient that goes to the operating room for an exam gets fixation. That's totally not true. And we treated this patient non-operatively and went on to a successful union. Another case example, that also involves potentially a low anterior column fracture. And here you can see on the examination that the patient showed multiplanar instability on our various views. And these are just 5, but the full series is 15 images on these exam under anesthesia. And this patient underwent fixation of the pelvic ring and went on to heal successfully. So Dr. Tornetta already covered this study, so I'll kind of go through it rapidly, but this was a pure series of APC2s, all with pre and post-operative CT scans to be included in the study. So we really scrutinized these rings very carefully, and these were all done by fellowship-trained orthopedic traumatologists at high-volume pelvic centers. And as Dr. Tornetta mentioned, when you add a screw in the back, you decrease the failure rate of your anterior fixation from 40% down to 5%, and your malunion from 35% down to less than 1%. So I guess the different school of thought is, rather than doing double the work in the front of taking out symphyseal cartilage that our creator put there, why not just add a screw in the back to address the injury to the back of the ring? And if you're a good pelvic surgeon with good fluoroscopy, you can do that very safely with minimal trouble. So this was already covered. So my current APC treatment algorithm is that if you're stable on exam under anesthesia, you're allowed to weight bear as tolerated. And if you're unstable, then you fix both the front and the back and protect weight bearing for 6 to 12 weeks, depending on the patient and injury. So now we're going into lateral compression, and historically these were thought to all do fine, even with a few centimeters of limb length discrepancy. And then, we started to see that patients with certain injury patterns, especially if it was a complete sacral fracture going through the dorsal cortex of the sacrum, and with either unilateral or bilateral anterior ring injuries, a third of them or 2/3 of them would displace late. So then we had the question, which ones of these are unstable because it's a third or 2/3, and which ones need fixation and how do you fix them? So again, the examination under anesthesia series found that about a third of the lateral compression type 1 injuries were unstable, and that 2/3 of the lateral compression type 2 injuries were unstable and underwent fixation. But in that initial series we did with Dr. Saji, we didn't really know what happened to those patients who went to the operating room, had an exam, and then didn't get fixed, or how do we know whether to fix both the front and back, or when to do these things? So the next series that I led up was looking at the results of our patients who went to the OR and had a negative exam under anesthesia, who were allowed to fully weight bear afterwards. And what we found is that none of them displaced. So there's very few things that are 100% in orthopedics, but we found that if you took them to the OR and put them under anesthesia, did a full 15 series exam, they didn't move, that they are going to heal without any displacement. So the next step then was to figure out, well, the ones that do move, how do we come up with some sort of algorithm and decide how to fix them? So took Dr. Saji's initial algorithm, and then we decided if they were unstable, we would fix the back of the ring and then repeat the examination for the front of the ring. And if it moved more than a centimeter in the front of the ring, then we would add anterior fixation. If it was a bilateral injury, we would then repeat it sequentially as we went. The argument here is that sometimes the back of the ring doesn't move much and the front of the ring moves a lot. So some people will only fix the front and leave the back alone. And even if some of my partners argue that, but I always like to fix the back of the ring when possible. So in this series, we found that for the vast majority, for 65 out of 74 patients, following this algorithm, they healed anatomically. There were 9 patients that didn't heal anatomically, and those were 9 that had bilateral anterior injuries that underwent posterior fixation, but without fixation in the front. So now I advocate that if you have a bilateral anterior injury, that you should probably fix at least one side. So our conclusions for this were that pelvic fractures are dynamic, that sequential exam can guide your fixation strategy and help you kind of make sense of what to do in the operating room with a simple, logical progression. And that if you have bilateral injury, that you should consider anterior fixation as well. So for lack of time, I'll kind of skip through these quickly, but these were a mother and son injured in the same accident who had a complete sacral fracture and bilateral anterior fractures. And this was the mother who moved on exam under anesthesia and then got the back fixed, moved again in the front, and so underwent anterior fixation and went on to heal with no displacement. This was her son who also moved on the initial exam. We fixed the back. And in the front, he moved some, but given the spermatic cord there and being 15, we didn't fix the front. He went on to heal with displacement, but that's the big question is we don't know the functional outcome of any of these things yet. There's a lot of ongoing work to figure out the functional deficit. But again, going back to initial statements of trying to recreate the way we were made, anatomy seems to predict function all over the body. So I don't know why the pelvis would be any different. The closer you can get to anatomic, the better. So for lateral compression injuries, for an incomplete sacral fracture, I allow those to weight bear as tolerated. If it's an elderly patient or somebody in extreme pain and can't move, I'll take them to the operating room, do an exam, and fix them with the protocol mentioned. If it's a complete sacral fracture going through the dorsal cortex, then all go for exam in my institution and then get fixed according to the protocol. And then we protect the weight bearing for 6 to 12 weeks, depending on injury and bone quality. So in conclusion, I think if nothing else, multiple authors now and further studies have come out more recently validating that the exam under anesthesia does have some value and merit beyond just static imaging of CT scans and plain films, that it can help guide you what you're doing in the operating room. But the big question is on functional outcomes and patient-reported outcome measures. How much deformity of the pelvis is tolerated? I think the jury is still out, and our patients will help guide us as we get patient-reported outcome measures in the future. Thank you very much.
Thanks a lot, Dr. Mir. And we have no questions. We almost on time for the next lot. But I would like to ask Paul. Paul, I'll just try to repeat something provocative, I think, which Hassan said, and said, why do twice as much work in the front when you can work in the front and work behind? And what I would like to ask is, when you are operating in front, like how vigorously are you looking for subtle posterior instability in your cases? And do you think it would make a world of difference if it was a very subtle injury and you were going ahead and fixing and fusing the symphysis?
Yeah, so I'm not fusing the symphysis. That's a sort of a misconception. The idea is to get better compression in the front. So, I guess if you haven't done it, you would have the misunderstanding of how to do it. But taking the cartilage takes me about, I don't know, a minute. It's disrupted usually on one side. You take an osteotomy, just scrape it off the other side, just scrape it with a curette. Maybe takes a minute, maybe 2. So it's not a lot of work to do. And what it does is it gets you bone-to-bone compression as opposed to cartilage. That's a very soft cartilage, which gets damaged during injury. So I've been doing it for over 20 years, and It doesn't cause problems, and it's definitely faster than, I mean, I can do that faster than someone can set up their inlet outlet views on their C-arm. So it's certainly much faster than putting something in the back. I think, unfortunately, the push in the United States is to do as much fixation as possible. And sadly, I think some of that is due to billing, right? So if I fix the front and I don't fix the back, I don't get to bill for a screw in the back. But there are a lot of people putting in a lot of extra screws, at least in my opinion. And some of that is undoubtedly financially motivated. Not all of it. I mean, there's some, there are 2 studies that show that by doing that, you decrease the failure rate in the front. What hasn't been done is there hasn't been a correlation of saying, well, let's everybody look at these patients and decide, like, is Hassan's paper and Chip Rout's paper, are those the same people that were in our paper for APC2s? We don't know that. So there's probably some element of judgment involved, where if you can adequately judge these injuries, you can probably decide when appropriately to fix the back and when you don't have to fix the back. That argument being given, I think if you have a big corridor and you're good at placing screws in the back, it's another option. It's just not one that I choose. I don't like to take any risk that's unnecessary. I'm generally an exceedingly conservative trauma surgeon. I operate on less than almost everybody else. I've been in the same place now for 22 years. I have a whole bunch of happy patients in clinic. It's not like I'm missing a lot of things, and people aren't coming back unhappy. So, I'm happy with my own treatment algorithms, and I think over time they've been proven out and published. So they're fine. Doesn't mean other directions are not fine also, right? So, to me, though, I think, if you're going to have a symphyseal injury, and I don't believe in APC1s, there's very few injuries that are symphyseal that I don't fix. I have 2 patients in my whole career in Boston where I just felt like I didn't do the right thing, and they were APC1s, and I actually got single leg stance films on them to show they were stable, and ambulated them, and they ambulated well. and both of them had less than a centimeter displacement, like just a little tweak. That's a different problem when they have pain down the line. So basically, I fix all symphyseal injuries. I think there's very few that I'm 100% comfortable will not have symptoms down the line. To me, that's a ligament injury, not a bony injury. They don't heal as well. It's not as stable. I don't stress them because I fix pretty much, unless it's a little teeny thing I can barely see, I'm going to fix all of those. If when you're doing that, you decide you want to do some stress evaluation to decide if posterior fixation is necessary, I don't have a problem with that. I don't have a problem if people want to add posterior fixation because, their experience level or their understanding of the injury is not good enough to say this is definitely a 2. Why take the chance? I have a good technique for the back, a big corridor. I'm going to put a screw. Again, I don't have a problem with that. I just don't opt to do it, and I don't think it's necessary, at least in my hands.
Great. The best and the fun part of listening to the professionals is that you can hear the 2 exactly opposite views, and both of them sound equally convincing. So anyway, I'll leave it to the audience. We move on with the next case presentation by Dr. Vivek Trikha. Dr. Vivek,
Yeah.
you're ready?
Yeah. So my slides, can you see that? Yeah?
Yeah.
Okay. So this is a case which I'll be presenting. It's a case and a story of a 38-year-old man who had an RTA hit by another car from the side and was slightly hemodynamically unstable. He was in the initial assessment in our emergency department. The ATLS protocol was followed and all the ABCDs were taken care of. The pelvic binder was put. We normally put in a pelvic sheet for that. And you can see the towel clips out there, which were holding the pelvis together. And once we were able to get him hemodynamically resuscitated with all the blood and the fluids and with the ABCs taken care of, then we went for his further evaluation. We can see in this X-ray, if we see that doesn't give us much clue about the fracture pattern. It just says that the symphysis looks to be opened up. And on the back side, not much is evaluated out here on this X-ray. Once the patient was stable and had come out from the ICU because of his other abdominal and the other problems, these were his views which we got done. Any comments regarding this from the experts? Paul, Hassan, or sir, Dr. Rajesh? Sir?
Yeah, so it looks like there's obviously wide diastasis of the symphysis in the front of the ring, in the and possibly some involvement of the superior and inferior rami on the left, involvement of the iliac wing on the left, and then in the back of the ring, clearly the iliosacral joint on the left is wide, and there's cranial displacement of that hemipelvis. It looks like the right iliosacral joint may be involved as well, and it looks like there may be fracture through the sacrum as well, although it's hard to see perfectly.
Yeah. So most of the things you have already described regarding the wide symphysis diastasis, which you can see, and the iliac blade and the left side of hemipelvis looks to be disturbed. So finally, when we got the CT scan, the three-dimensional CT scan showed us this picture. And if we see on this CT scan, we can see that most of the things which were there, the crescent sort of a fracture of the left ilium, the symphysis which is opened up along with the pubic ramus fracture on the left side. But when we look at this CT of the 2D pelvis, this is the thing which we find. Hassan, Paul, your comments regarding this? How often have you seen this sort of a fracture pattern, and how do we classify this pattern of fracture of pelvis?
Yeah, I mean, it's, you know, it's a combination injury, right? So, you know, the acetabulum is thankfully protected. So it's a separate fragment. So I think I would still just classify this as a pelvic injury, not a combined injury, right, just because there's nothing through the joint of the acetabulum. And it's just, you know, it is interesting because you know, on that AP, there was a little inferior area that looked like a fracture dislocation pattern, even though the rest of the SI joint kind of looked okay. So I think there's maybe some shift within that SI joint, even though it's primarily a crest injury. So, you know, that's one you'd have to look at directly. The nice part about this is you've got some pretty large fragments to deal with, you know. So for me, the tactic would be to start in the back, sort of Lardinell's golden rule, start in the back when you don't have a symphysis as your primary injury. So the only time I start with a pelvis in the front is when the symphysis is out and the innominate bone is intact. And that rule comes basically straight from Lardinell's work, right? So you can bring everything back. But if the symphysis is out, but you've got also multiple injuries, the crest is out, you're going to start in the back here. So I would start in the back. I'd start to build it. I would do an anterior approach to be able to look at the entire crest and also look at the SI joint, because it looks on that lower left image like part of that is the SI joint, right? That's attached to the pelvis in that area that you can see, you know, kind of right here. So I would build that back, you know, paying attention to watching the front at the same time. And once you get that established, then the issue is going to be, what do you do for the anterior ring, which you could potentially do that through a stappa and get to that entire area. I think I'd want to fix the symphysis. So I would probably just extend a plate along and reduce the symphysis and the high ramus fracture, but I don't necessarily use one plate. I think you can use separate plates for that. It's really hard to contour one that goes all the way around. It looks pretty, but it's not any more mechanically stable. So I would probably do a simple plate in the front. If I could get the back aligned well, that, you know, the ramus aligned well, I'd extend the plate around. If it's easy, if it's not easy, then I would just use a separate plate for that. I know other people may use a screw, but to me, I think extending a plate over and just one screw above the acetabulum is pretty easy to do through that medial window. So it's an interesting injury though. And neuro intact or no? Was it neurologically intact?
Luckily for this, the neural was intact.
Lucky, yeah, very lucky with that kind of anterior displacement.
Yes, exactly. This part of the thing, which is lying above the sacral area. Hassan, you wanted to say something?
No, I agree with Paul. I would do an AIP and a lateral window. I think that through the AIP, really that helps you to reduce that crescent fracture, actually pushing from the inside of the pelvis out to lateralize at the sciatic buttress at the front of the SI joint. And between that and your lateral window, try to get it secure, potentially a small plate there to help secure it. But I think your major fixation for that crescent is going to be an LC2 screw, starting at the anterior inferior iliac spine and going towards the PIIS. And because your iliosacral screw here wouldn't really capture the unstable portion. Also probably plate fixation or screw fixation up along the ilium there. And then I agree with Paul in the front, 2 implants, one for the symphysis, And then I would probably do a ramus screw as well.
Right. Dr. Rajesh or Dr. Vikas, any further comments, or we go ahead?
Go ahead.
Okay, so this is what we were seeing, and I would like to say that when I researched, we thought it was a sort of a combined injury with a more component of a crescent fracture, which was seen out here. If you look at the back with the sacroiliac joint on the posterior side being normal. And it's a subset of LC2 sort of an injury with the open diastasis, so makes it combined injury. But most of the things, when we see this pattern in an axial CT scan, what we find is that the sacroiliac joint is shifted posteriorly, and it is a subluxation which is happening posterior. And this is the day classification, dividing it into 1, 2, and 3, saying depending upon the size of the posterior fragment and how and where you can put in a screw or iliosacral screw or put in a plate or the anterior side, depending on whether it is a type 1 fracture where you would put in a plate, or maybe type 2 or 3 as shown by chip route that you can put in easily some screws. But for me, this was, and that's what we said, that this sort of a fracture, and as rightly pointed out, that here the sacroiliac joint was opened up and was having a partial fracture dislocation. So we said it is a component of a having major compression injury in which the ilium has shifted, and instead of going posteriorly subluxed, it is subluxing and going anterior. The points to note was that it was an anteriorly displaced fracture dislocation of sacroiliac joint. And as was discussed, L5 nerve root might be damaged. It is just lying next and adjacent to it. And that was the critical thing. If you look at the CT angio also, you can see that the common iliac and the bifurcation of it is also just adjacent to where this fragment is going to go. So it's a pretty uncommon injury. I looked at the literature. I could find only 2 cases at that time. This was around 8 to 10 years back that I fixed this. And there was only that too in 1970s late, where they had a polytrauma cases, and they had a pretty bad outcome out of these cases because they couldn't make sure how to go about fixing these. So we went about anterior approach or posterior approach. So that was our question. Mostly in crescent fracture, when we go, we can fix that posteriorly as well, because then the rotational element as well as the displacements can be easily found, and you can correct them properly both from the LC2 screw part or as well as putting in a plate out the outer side. But here we thought that it will be better to see the nerve as well as the vessels if we can have any problems. And we went about fixing that from the anterior side, putting in a Steinman pin at the inferior spine or the iliac crest and just lifting it up, making sure it is not rubbing the sacral ala, because if it rubs the sacral ala while reduction, it is going to cause. What is crucial is that the sacroiliac, the ligaments out there, the sacrotuberous or sacrospinous may not be broken that much. And if they are not broken, if it is old fracture, to reduce that is going to be very difficult for us. And that's how we were able to preserve and visualize the L5 nerve root and make sure that it was protected. And as was said, we fixed it with 2 plates. Here, we went about with the lateral window. This is around 8 to 10 years back, as I said, with a fan and steel. And this is the incisions which we took. We had a plan that we will, after reduction, we'll put in the screws out there with an additional plate, which is going to fix the posterior fragment along with the interior fragment. And then we will put in a normal SI joint plate, which is there, which will be fixing both the fragments with the sacrum, which is intact out here, and the ilium to it. And in the front, we will be doing the same reduction with the symphysial fixation, as well as here we put in a screw out there. So this is the fixation which we got at that time. This is his follow-up after 1 year, where the things had united and he had good motions. This was not a young, and over the years, we have had opportunity to treat around 9 to 10 cases now of such fracture. You can see here also, if you find out this inlet view, the entire sacroiliac joint, which has partially fractured and is dislocated anteriorly, lying in front of the ala. If you see the CT scan of the 2D scan as well, you will see that it is having an undisplaced sacroiliac on the opposite side crescent, the standard normal crescent on one side, and this sort of a crescent on the other side, which is a type 1, type 2 sort of a fracture. And here it is the normal crescent. We went about the same way The LC2 screws were put percutaneously afterwards while putting in a prone position, while these were put anteriorly. We always went to go anteriorly, look at the thing, look at the nerve root, ensure that we are not pressing it, and make sure there is no vascular injury which can happen out here. Another case.
I like the fact that that you're doing these, primarily these complex ones from the front, because while people think the crescent fractures are always intact at the sacroiliac joint, they're not.
Yeah.
And with this pattern in particular, you can have SI joint instability even after you fix the ilium and have instability through that. And the way you're doing these, you're able to look at the SI joint and put a little plate across. So I really like that technique. That's an important point.
This is another bilateral crescent. One, the classical crescent, which we see on the left-hand side, and the new variant, which we found with the anterior sacroiliac dislocation lying on the left. So we had two cases like this, where you can have a bilateral crescent having this fracture pattern. Again, went both from the lateral window, just lateral window from both the sides, and it gives you good reduction for both the fractures. He had some anterior injury and the abrasion, so we didn't fix it anteriorly. And another case, which is again showing the same thing, ala lying, the ilium lying in front. This is a variant, I would say, of a crescent fracture, which is not going posteriorly. The vector component is going from posterior to anterior, and maybe the ilium is just going and just cannot recoil back once the fracture has happened from the SI joint crescent sort of a fracture. And exactly the same thing which we did for this part, and the crescent was fixed like this. We published this in one of the case series in our Indian Journal of Orthopaedics also. And in the end, I would say that yes, normally we see the crescents, which is a posterior, relatively stable injury, which can be treated from the back side or the front. But what we have found over the years, in the last 10 to 12 years, that there can be some anterior, and this is slightly different injury from what we normally see. We have to be beware of taking care and proper protection of the nerve root, which is very essential, and do it as fast as possible, especially our Indian friends, because I had a case which was 3 to 4 weeks old, and it was so difficult to reduce it because the ligaments have contracted by that time, and you cannot fiddle around there with your common iliac bifurcating along with the L5 nerve root there. So you can have a horrible time reducing them in a slightly delayed case. Thank you.
Thanks a lot, Vivek. That was a very interesting series. Great job. I'll now invite Paul to present a case of failed sacral fixation.
Okay, so I always think I learn more from things that didn't go well. So this case is, you'll note, is a fairly old case. So it's a 43-year-old hemodynamically unstable with a pretty significant head injury that ended up with just a bolt and high ICPs. Didn't need any kind of a craniectomy, and was intubated in the unit. Was cleared by the trauma service. This is the kind of stuff they always tell us. Well, you can do a short procedure. They were pretty unstable. You can see here, a very unstable sacral fracture with cranial displacement, bilateral complex rami. Ones that you'd want to fix the front and then either use a frame or do something fix the back and then do a frame or something in the front, or, if you wanted to use Ramus screws or plates, whatever your choice was. But you can see the comminuted injury of the left sacrum here. It's a pretty significant amount of displacement. So we treat these early with traction. So they went immediately into traction, was in the ICU in traction. And at that point, I said, what are the options? So you could do 2 open approaches. You could ORIF the front, then the back. You could do the back, then the front. You could do percutaneous fixation of the sacrum if you can get good alignment, and then do something to the ring or put a frame on the ring, or just do fixation in the back alone. This is just the CT sort of showing, nothing surprising, I think, for anybody. Unilateral injury in the back and bilateral injury in the front. To me, that CT didn't tell me anything I didn't already know. So again, we go to these options. So what I did was we brought the patient to the operating room. I'm going to use this parallelogram type of attraction where I put a chest roll against the affected side with a bolster. It's actually a hip positioner, and then put the other leg in extension, and you pull traction through this side, and you can actually titrate the reduction pretty well. I think this case was probably 11 or 12 years ago. So you can see I put SI screws in, two S1 screws I would probably use in S1 and S2 now. And my fixation construct, I think, would be a little bit different now. And this was sort of one of the cases that led me to change a little bit what I did. At the point where we're putting the second screw in, the patient actually almost coded. So we got the second screw down and the patient got brought back to the ICU in traction, again, intubated and theoretically paralyzed. So, you know, we plan to let the patient settle down in traction to protect the fixation, to protect the anterior ring and our posterior fixation, and then come back as soon as the patient was stable. And they were intubated, sedated for their head injury and, you know, head of the bed elevated, the whole deal. So I went away for 3 days to a meeting, and I came back. I said, all right, well, let's just get a portable and you know, be able to plan, because probably in a couple of days we'll be able to bring the patient back. And, you know, this side looked the same, but this side didn't look quite the way it used to. So obviously this was a fairly dramatic early failure. So this is a patient, again, who's in the unit, in traction, theoretically sedated so they're not moving because of their head injury, that obviously was bucking and moving around. But you can see the kind of early failure you get when you don't have enough stability in the ring. So then my first reaction was this, and then I had to think about, what am I going to do now? So, you know, at that time, very few people were doing transsacral screws. Like, I put long screws in to get to the other side, but there was a real concern around impinging the other side. And we used to do it only really for tumor cases. So I got a CAT scan of this. This is what it looked like. You can see the deformity is back to where it was. The screws are in the lateral segment. But the CAT scan showed that the track that we had, fortuitously, because we went to the other ilium, I mean, the other side of the sacral ala, probably would suffice to go all the way across and grab the other side. And you can sort of see that on these cuts. And then here you can see the same thing on the sagittals, where those screws are going through in a relatively safe area to maybe go all the way across. So the patient was still intubated. Their blood pressure was still highly labile. What would you guys do at this point?
Mm-hmm. In my hands, what we will be doing is, yes, if possible, the transsacral screws right now in our present day world, but not before 5 or 6 years before. But what we normally do is we put in a transiliac plate by having it in a prone position, and that's I normally reduce these fractures in a prone position, see the fracture which has been reduced properly, then take out a small ticket of PSIS as a window, slide in my plate down, as Landorfer from Austria, they have described that in JOT. And so that's how we put in a transiliac plate, which holds that. And it's you can say a cheap version of a transsacral screw, but it helps a lot for rotation.
Right. And would you do at this point, because it's, you know, she's now probably, by the time I got back, I think 7 or 10 days out, would you do an open reduction, or would you try to do a closed reduction at that time frame?
It depends upon her physical habitus, how exactly she is, but normally, if it is displaced more than...
She was not in contradistinction to most of the stuff we have, she was actually not morbidly obese. She probably had a BMI of 32 or something, so she wasn't huge.
Okay. So I would still try to get it a reduction, but in my hands, mostly if it is more than 1.5 centimeters displaced in the beginning, I go prone, reduce them in my vision, and then put in the transsacral screws or a transiliac plating at the same time.
Yeah, and that was certainly one of the options I had. Anybody else? Hassan, what would you do? Would you?
No, I would repeat the procedure, supine again, get it reduced again with bed assisted traction, and then I would add transiliac transsacral fully threaded screws just to really lock it up, and then potentially look at the S2 segment to see if I could add even another screw just to really lock it up, and then definitely add anterior ring to help bolster the posterior ring.
Yeah, and that pretty much is this. That's great. That's perfectly sort of the spectrum of what I was thinking, right? So my plan was, I didn't think there was going to be a lot more room in S1 to find a new corridor, but because those corridors looked pretty good, just by happenstance, you know, by putting the screws far across, my plan was to bring it to the operating room, put it supine, just like Hassan said, re-reduce it in the same way that I did before, and then, you know, just take a guide wire, put it through my screw, which was really not very hard to find because it was sitting out this far, and see if that tract was still intact. Like, did I get the reduction close enough that corridor and that screw tract would still be good? And if it was, then I was going to go for, you know, I use partially threaded screws because I wanted to maximally compress this, but go all the way to the other side. And then, you know, my thought was if I either couldn't reduce it well or the track really was pretty poor, I take the screws out, flip it prone, and do an open reduction, as Dr. Trick has said. So I sort of both things in my head, and I was hoping for the best and expecting the worst. I usually get the worst, but that's what we were sort of hoping for. So here you can see the reduction again, and as it comes into intraction. So this was my sort of attempt. And if that failed, then I was going to go with posterior plate and screws, not add anterior fixation if I did that. So we were lucky, and when we pulled it back down, we were able to get those tracks again. So these are the original screws that were in initially on the bottom one, and the top one is sort of a new screw. So you can see we went all the way across through that same tract. And again, I used partially threaded screws, and I lagged the crap out of it. So I compressed it and it got really, really good bite. And then I didn't fix the front because I wasn't too worried about the rotational instability. This is what we ended with. I think today I would probably fix the front just to give myself some additional support. But when we put these screws in, we sort of evaluated it. When we took the traction off, I did flex extents views. And nothing really shifted very much. And I would agree with Hassan that, you know, this was really before transsacral screws were being used very much. And at this point, even my standard for this would be an S1 and an S2 transsacral screw. So I definitely would have, at the current time, taken that S2 opportunity. But at this time, this was sort of our revision. And this went on to unite pretty well. The head injury actually resolved, and she became very high functioning again. But it's my only my only sacral failure. It's pretty early, and I think, you know, you can learn a lot from this, right? I think had we been able to get a frame on in the OR even and traction, I don't know that this failure would have occurred. And, you know, in the current day, I think we would all go with these comminuted injuries with transsacral fixation and then trying to get good compression of those fractures.
That was, again, a great case, Paul. I think a lot to learn. And I was just wondering if the patient hadn't deteriorated the first time and would have gone all the way, would there have been chances of, I mean, was it your initial plan to fix anteriorly, or you would have been happy just with the posterior fixation?
Yeah, no, I was with the shorter screws, I was planning to put a frame on. You know, so I would typically evaluate it in flexion extension a little bit just to understand what kind of instability is present after the back. And, you know, if you look at Joel Matta's paper, you know, anterior fixation when you had accurate alignment in the back and compressed was unnecessary in most cases. So I didn't really get a good understanding of how much instability there was here. Because we had to rush out of the operating room. So the plan was to evaluate that and decide, and we didn't really have that opportunity. And since I was keeping the patient in traction, I was happy with my posterior reduction because I thought it looked very good. My hope was that, you know, we would get back to the operating room to sort of make that decision at a later date. And unfortunately that got waylaid.
Yeah. We have a few minutes for discussion. We still don't have any questions, so I got a couple of minutes. So I'm coming back to Vivek for your case which you showed. Hassan suggested, and I understand that you did this case long time back, but Hassan suggested that anterior intrapelvic approach with lateral window could have taken care of that. So my question is, today, if you get the same injury, would you do it the same way you did it earlier, or would you now like to go for something like what he suggested, anterior intrapelvic with a lateral window? What would be your choice now, frankly?
No, still I would be going along with the lateral window one. Why? Because this sacrum was lying in front of the ala, and it was going right up to the mid raphe of the sacrum. So if I have to reduce, I'm not that. He has learned it from Saji and he has been doing it himself with so much expertise. I am not so confident of going right in front of the sacral center point and able to reduce my reduction if it is not happening that way. Yes, after my reduction has been taken care from the lateral side, then when I'm opening from the interior symphysis, then the routine exposure from the intrapelvic can give me a pushback, which will be able to push back that reduced fragment to a minimal 1 or 2 millimeters of the exact sacroiliac joint reduction. But the initial reduction, I would still prefer to be going it from the lateral side, opening up with maybe an ASI osteotomy to be looking so that I can go just inside if anything is going to happen. Because from intrapelvic, I won't be sure that I will be able to get that exposure at the mid-sacral level. Maybe Hassan, you can say.
Yeah, no, I agree. I would work through both windows.
Yeah.
It's just that I think that the force you can generate from the
Exactly.
interpelvic window to push that fragment laterally
Yeah.
is more force directly pushing on it with a ball spike pusher. But certainly starting at the lateral window to make sure that the L5 nerve root is not entrapped when you're pushing from the intrapelvic window.
Yes, exactly. The minor adjustments will be much better done from the intrapelvic side. And those adjustments can be done from there, but initial is more still from the lateral side. That's what I felt.
Paul, coming back to your plan, I remember a very famous quotation. It said, anybody can perform the operation, but a real surgeon is the one who knows how to get out of problem. So I think that the condition which you saw when you come back and see everything has fallen apart, I think that is the time when, and there's a great lesson here. And I think it was a great idea to pass the K-wire through the cannulated screw, find the same track, and then go on and extend your fixation to the opposite side. I think that's the great lesson here. I would like the audience to pay attention to. I think it's the 2 or 3 things I always say. Don't lose your cool. Think about it. I mean, the plan which everybody, which actually Vivek also said, there was nothing wrong with the plan. But then, when you are in a complication, I think you should find the easiest way to do it, and probably the way you try to track the same holes and extend is a lesson far beyond this particular case. I think you should be very careful in choosing how you are going to fix the problem which has occurred. And I always say, don't hesitate to ask for somebody else's opinion once things have gone. Of course, doesn't apply to you, Paul. I'm sure I'm not talking about you, but
no, you can talk about me. I couldn't agree with that more. I mean, I think the more you know, the less you know, right? I mean, I can tell you, my first year in practice out of fellowship, my confidence level was far higher than it is today. There's no question in my mind that that the more you experience and the more that you do, I think even the more of a perfectionist you are, and when you think about what you're doing, the more you know, the harder it becomes, because you just, your acceptance of any even fine amount of displacement or anything that doesn't look right is becomes so low, and you recognize so much more. 20 years in practice, you recognize more than you do your first year in practice. I mean, if you don't, there's a real problem with your learning curve. So I ask people's opinions all the time. I have no problem with that. I had a case the other day. I was doing a humeral non-union, and the radial nerve just looked too small to me, and my hand surgeon was across the hall. I said, just come in and look at this radial nerve and make sure you think it's actually the radial nerve. Like, I just want to make sure everybody agrees. Like, what's the downside, right? It's all about the patient. Like, the day that your pride is greater than your empathy, like, you need to get out of this job.
Sure, and you exactly echo the sentiments which the great arthroplasty surgeon Larry Dodd in his book in the first chapter on total hip replacement. So I think we all need to learn as much as we need to learn about the techniques. Great, gentlemen. I think it's time to move on to the next session, which is the acetabular fracture. So I invite Dr. Hassan Mir to give his talk on the acetabular fixation through anterior intrapelvic approach.
All right. So we'll get started on this. So this is going to be a short talk followed by a video showing how I do the anterior intrapelvic approach. And again, my disclosure. So the ilioinguinal approach is what I was initially trained on and what probably the vast majority of pelvic and acetabular surgeons initially learned. Some of our trainees now have not actually done this approach and are only learning the AIP and modifications. But this was initially described in 1965 by Letronell, and it's for patterns with anterior displacement. So all the patterns you see there. And the middle window, which is very valuable for reduction and implant placement. It does, however, require dissection of the inguinal canal and femoral neurovascular bundle, and then a proper repair following that. And so that's what makes people a little nervous about this classic approach who haven't done it. The other thing is that this approach really has been modified over time by several surgeons for the medial window, not actually being more of an AIP approach. So there's a lot of surgeons who say they do a classic ilioinguinal approach, but actually it's modified because their medial exposure is through an AIP. So the AIP is an intrapelvic approach that was initially described by Stappa and Reeves for repair of inguinal hernias using Dacron mesh. And it was then further described in the 1990s by Dr. Hervin-Salo et al. And then Dr. Dean Cole and Brett Ballhoffner here in Florida. And so this was utilized for fixation of acetabular fractures. And the advantage of this, an intrapelvic approach that's extraperitoneal. So you're not having to get anywhere near the intestines, but you can deal with acetabular fractures, through an approach that was familiar to a lot of pelvic surgeons already working on pubic symphysis injuries. So this has been well described in the literature now. This is just a sampling showing that you can get really good anatomic reductions through this approach. The folks who were resistant to change and were very much in favor of sticking to the classic ilioinguinal said, well, without the middle window, you can't get things reduced, you can't get things fixed properly. I think that's been well established that that's not the case now. So this was an early study that we did looking at what can you actually see and instrument through the modified Stappa approach, through the anterior intrapelvic approach, same thing. And so this was a cadaveric study where we did this on 10 cadavers and then used a drill to mark where we could actually see. So we didn't drill beyond where we could see. We did what we could actually see in these cadavers. And on average, it's about 2 centimeters above the pelvic brim, 5 centimeters below the pelvic brim. And you can get all the way from the symphysis back to about a centimeter onto the sacrum. So it gives you a pretty wide exposure if you know how to mobilize and move your retractors. So this isn't just with one single retractor placement. That's very important to note with this exposure. Just like the ilioinguinal, you have to be facile with moving your retractors, using your assistance properly to get a good view of really what you need to see. Now, when you add a regular lateral window, and I have this in yellow because it's really hard to see everything, but you can certainly get to everything as far as palpation and instrumentation through a lateral window. And then, as was mentioned earlier by Dr. Trika, if you add an ASIS osteotomy, now all of a sudden you can see, instrument, clamp, and do really everything that you could from a classic middle window and ilioinguinal approach. And this ASIS osteotomy, again, the advantage of it is that you're leaving the inguinal ligament and canal completely intact. And then if you can't fix an ASIS osteotomy, you probably shouldn't be fixing the thing that requires the ASIS osteotomy, if that makes sense, right? So this has been described in the literature as well. Usually it's a step cut osteotomy between the ASIS and anterior inferior iliac spine. You do elevate on the lateral side of the ilium to get a good view. The one difference thing is that when you're doing your lateral window, if you think you might need an osteotomy, make sure to stop your external oblique elevation. Don't take it all the way off as you normally would from a lateral window to try to improve your visualization, because then you lose the muscular attachments on the osteotomy, which probably at the end of the day, you could sew it back down and it will do all right. But if you can off the bat think that you might need the osteotomy and leave those muscular attachments intact, it's easier to reduce and fix at the end and probably more stable at the end. So this just shows how much more visualization you can get. You can see this is without the osteotomy. You can't really see that well, and it's hard to get your lighting in and everything. But when you add the osteotomy, the entire hemipelvis just opens up. You can get to midline on the sacrum with the osteotomy, and then working anteriorly, you can get all the way down to the pubic root quite easily and work on any anterior wall and pubic root components of your injury. And this essentially gives you clamp trajectories and implant trajectories similar to what you would get from a middle window of an ilioinguinal. So now the AIP.
This is a video demonstration of a modified stop-go approach for intrapelvic exposure. The patient is supine with a bump under the ipsilateral thigh to relax the iliacus and psoas muscles. The incision is a standard 12 centimeter fan and steel incision, approximately 2 centimeters proximal to the symphysis. The lateral window can be added in cases that necessitate that exposure. After incising the skin, the subcutaneous tissues are elevated. This dissection is performed in live surgery with wood-handled elevators and electric cautery to maintain hemostasis. Subcutaneous flaps are developed proximally and distally to aid in exposure and mobility of the surgical window. It's most important to develop this approach in the cephalad and caudal directions, as these will aid in deep visualization. Lateral dissection places the spermatic cord at risk. The fascial midline can be further identified by the crossing fascial fibers of the external obliques. It's important to gain vertical length to allow for a long split to aid in intrapelvic visualization. Blunt dissection is carried out between the left and right rectus abdominis muscle bellies and into the space of retias to avoid injury to the bladder. A deaver is used to retract the rectus. A moist lap as well as a malleable retractor is placed to protect the bladder with care to avoid injury to the neck of the bladder. Subperiosteal dissection is then performed along the superior ramus. Once past the pubic tubercle, a sharp Hohmann retractor can be placed over the ramus, which will greatly aid in intrapelvic visualization. The line on the model upcoming shows the area for the next part of the dissection. We proceed cautiously after this point to avoid cutting or tearing of corona mortis vessels, as they may be under tension, especially with medially displaced fractures. A Schanz pin may be placed percutaneously into the proximal femur for an assistant to provide lateral traction. The deaver and malleable retractors are repositioned to mobilize the window as we move laterally. The obturator neurovascular bundle is identified as it courses anteriorly to exit the superlateral portion of the foramen. Corona mortis connections are identified, which are ligated with vascular clips prior to further lateral dissection. The malleable retractor can now be repositioned to protect the obturator bundle as we dissect posterolaterally along the pelvic brim and quadrilateral surface. The obturator internus muscle belly is elevated to expose.
So the audio fades there, but it's just talking about exposing the quadrilateral surface now back to the greater sciatic notch.
This can also be carried posteriorly towards the greater sciatic notch with care to avoid damage to the superior gluteal bundle. The iliopectineal fascia is carefully released to allow access to the false pelvis above the brim. The external iliac vessels must be carefully protected with a deaver elevator. We now have exposure of approximately 2 centimeters above the pelvic brim and 5 centimeters below the pelvic brim. A sharp Hohmann over the anterior acetabular wall and a malleable retractor posteriorly may help in widening the exposure. In our cadaver study, we performed the stop-go approach on 10 specimens and then used a drill to mark the boundaries of exposure. We then stripped off all of the tissues and calculated the viewable surface areas and boundaries in relation to the bony landmarks. Please see the article for details of our findings.
All right. So just a few quick case examples to show what can be done through the AIP and lateral window. So this is a gentleman, 65, who fell from a ladder and has this anterior column posterior hemitransverse fracture with a dome impacted segment. Here you can see on the ghost reconstructions from the CT scan, again, the fracture pattern there. And then here you can see the impacted dome segment is visualized. So working through the lateral window in the AIP, you can see a small buttress plate through the lateral window to help reduce the posterior extent of the fracture of the anterior column. And then working through the AIP, we can directly visualize and manipulate the dome impacted segment. And then we're able to close the anterior column anteriorly with another small buttress plate. And then added our posterior column clamping through the AIP interval. And then this was our final construct, which, you know, this is short plates here, but you can easily place long plates above the brim as well, working through both windows. And so this is the final CT scan and shows that we were able to get the dome impacted segment back to a good alignment. The columns look good, and the rest of it's well aligned, working through these less invasive, although still dangerous approaches. And this was this patient healed. Another example of a T-type fracture in a young 17-year-old female with a marked displacement medially. And here she was after being placed into skeletal traction, large hematoma. You can see shifting her bladder across the midline. And then this is work all done through an anterior intrapelvic approach. This was reducing the posterior column fracture, and then working through the AIP. When you actually look at the image on the left-hand side of the screen, the iliac oblique, that looks like a plate that we would put on the posterior column on the retroacetabular surface, but this was actually placed intrapelvic, and you can see that on the obturator oblique that is on the other side of the pelvis from where you would normally see it. And then we went on to be able to address the low anterior column portion of the fracture and got it reduced and buttressed. And then here's her postoperative CT scan showing good alignment. She also had an iliostacral joint injury on the same side. And then here she is healed at a year. So thanks for that, and happy to take any questions afterwards.
That was a great talk. And now I'll be speaking about the arthroplasty in acetabular fractures. And so the learning objectives here is are what's the role of total hip arthroplasty in acetabular fractures. We are going to discuss the delayed versus the acute total hip arthroplasty, the 10 commandments for performing THA in acetabular fractures, why acute THA in elderly, and the choice of implants and whether we need the special implants. So this is 1993, and the role of total hip arthroplasty in acetabular fracture was primarily if you had post-traumatic arthritis, or you had malunion or non-union of the conservatively treated fracture, or if there was immediate hip arthroplasty needed in certain displaced fractures with a poor prognosis. Now, from there, by 2013, we had extended the indications, even though with the same goals. So this paper talked about doing arthroplasty for proven poor outcome with open reduction tunnel fixation or conservative treatment. That means if the patient had radiological features of osteoarthritis, AVN, fixation failure, or impairment of function, which would lead to a delayed THA, or predictable poor outcome with open reduction tunnel fixation. That means severe combination, not amenable to reconstruction, dome impaction, femoral head impaction, and in the elderly, where you would undertake acute THA with or without fixation. Let's talk about the 10 commandments for delayed total hip arthroplasty in acetabular fracture. The first, of course, in any operated case which fails in orthopedics, the first rule is to rule out infection. So always exclude latent infection, do an ESR, CRP, aspirate, and if you are in doubt, do a two-stage. Like this case, who was fixed, ESR was 58, CRP was 117. It was operated elsewhere. The first stage involved removal of all the implants, and it actually, we routinely sonicate these implants at our center, so we have an opportunity to get the type of bug which was infecting. The second is the abductor status, because that's so paramount for a good functioning, stable hip arthroplasty. So look at the greater trochanter contour on the X-ray, feel the muscle, test the strength. You can also do the Trendelenburg test. So this was a case who had fracture of the acetabulum with the proximal femoral fracture, which was infected, debrided, and implants were removed. And when it went for the second stage, we could find the bare greater trochanter devoid of any soft tissue attachments whatsoever. The third rule is the distal pulsations and the nerve function must be ascertained. Palpate the vessels, all the peripheral vessels, do a CT angiography if required, or MR neurogram for documentation in the case. So you can see in this particular case, see the proximity of the vessels to the implant, and this is a case where an MR neurogram was done. And for those who can understand uh, our Hindi, I think there's a mention of a short commentary on when the radiologist is showing the sciatic nerve here, and as the scans pass, you can see actually it is quite close to the hardware. So it is possible to actually exactly map the sciatic nerve and see whether it's close to the hardware. And particularly if you find a palsy after any kind of surgery, we routinely perform the MR neurogram. The fourth is look at the amount of shortening and the range of motion at the hip, knee, and ankle. So often these cases, if they are associated with proximal femoral fracture or otherwise, can have upper and greater trochanter, shortening of the limb, other injuries in the ipsilateral limb, knee, and ankle movement. The fifth rule is to quantify and plan for managing the bone defect. So you will need to assess the need for grafts and augments, presence or absence of pelvic discontinuity, which may surprise you. You may not be expecting it. The need for augments and buttresses when the head is not available. So this is an example which had a pelvic discontinuity, and it needed the special technique I'm going to talk more about. And if you don't have a femoral head, you will need to put these buttresses to take care of the bone loss. So you have to be prepared all the time. Look at the previous scars and the approach. Follow the previous scars. So most often the posterior approach is the one which is used quite commonly. Then expect the scarring, the blood loss, and of course you have to keep in mind the injury to the neurovascular bundle because of the resurgery and the scarring. The next one is the choice of the acetabular shell. So now we have a lot of modern porous coated shells available. We prefer the multi-hole shells with provision for additional screw fixation, but then it's ideal if you could have the provision for additional hole creation, and then dual mobility cup is a new attraction. So whenever we operate on these complex deficient acetabuli, we always want to put in the kickstand screws down there, because if it's not uncommon to find a lot of bone here. So the temptation is to put a whole lot of screws there, and the cup can just tilt out unless you put these screws in the pubis and ischium here. Then think about the hardware in situ. So identify the implants which need removing. The implants have often been in place for several years, and removal may be difficult, and then that can weaken the bone post-operatively. So we say don't fight hard with hardware. Only remove those implants which are coming in your way. So that is, it eases the surgery, minimizes complications, reduces the duration and the blood loss, and does not compromise the bone strength. But you may need these special techniques and the metal cutting birds for these. A 30-year-old male had ORIF 2 years back, developed avascular necrosis. You can see these two screws, which could actually be seen inside the acetabulum. And if you're prepared with the hardware removal set and retain the hardware which does not come your way, you can see those two screws have been removed, but everything else has been left, because there's no point in unnecessarily complicating the surgery and increasing the duration of surgery with more loss, and as well as the risk of neurovascular injury. So this is the follow-up X-ray. Another example, you see these two screws, 41-year-old female, 9 years back, the fixation was done. And you can see this one screw needed removal, but then we let everything else be where it is. 51-year-old male, 2 years back, ORIF, developed secondary osteoarthritis, and you can see the inferior part, the inferior screws had to be removed, and that's the follow-up X-ray. 59-year-old female, again done 2 years back, and then you can see that the hardware, only that hardware which is coming the way is removed, and notice these screws in the pubis and ischium which have to be put in. Another example here, and you can see the trochanteric screws had to be removed here because they were a cause of recurrent bursitis, so they were done away with, and the surgery was done, and this is the follow-up. Fracture dislocation right hip in a 37-year-old male, and ORIF was done elsewhere, and developed secondary osteoarthritis infection with the loss of femoral head. So 10 months after the index surgery, the debridement and hardware removal had to be done, and the total hip could be done after the markers were negative. And another case, proven negative, I mean, suggestive of the infection control by the markers, and it's even the acetabulum is so supportive that you can actually put it without any screws through the dome, and this the follow-up. This is a 63-year-old male who had ORIF 4 years back, and this is the surgery done, and this is the 4-year follow-up. This was a very interesting case. 47-year-old male, diabetic, hypertensive, and cardiomyopathy. He had an ORIF done somewhere else, developed secondary osteoarthritis, underwent total hip with the primary surgeon, and surely enough, it got infected. An implant was loosened. He had a permanent pacemaker put in, which was infected, so there was a focus of infection. It was very difficult to take out. So debris and implant removal was done after the pacemaker was taken out, because that was the focus of infection, infection control, and this was the definite reconstruction, and this was the follow-up X-ray. A 27-year-old male had a fracture dislocation of right hip with a foot drop, and the remnant head could be used in this case for reconstruction, and this is the follow-up. A 40-year-old male, road traffic accident at 22 years of age, underwent ORIF, developed secondary osteoarthritis, underwent resurfacing after 3 years, and this lasted him good 15 years, when he presented with pain and heaviness and a big pseudotumor. And this was a revision surgery because he was very young. He was revised with a short stem and continues to do very well. And this was a HVS antigen positive patient, neglected fracture dislocation, previously not operated, but needed a major reconstruction with the femoral head. And you can see the screws to enhance the stability here for these cases, and this is the follow-up. Another interesting case, this was an army official who had a railway track injury, fracture dislocation of the right hip, bilateral below knee amputee who developed avascular necrosis of the femoral head, and this was reconstructed. And another example where the fracture dislocation of the left hip attempted or it failed, and developed infection, debris, KVL removal, and then it was done with the you would see that some of these are done with the modular stem to take care of the issues with the limb length and the stability. Now, just going to talk about the acute total hip arthroplasty and acetabular fracture. Like I said, if you anticipate poor prognosis with fixation, the two most important bony landmarks for acetabular component fixation in these cases are the subchondral bone attached to the AIIS and the subchondral bone attached to the ischium. If you can wedge your cup between these two, you are good. So everything else is a secondary fixation, and this is the one which gives you primary fixation. So this is a case which had severe comminution, 38-year-old male. The hip was dislocated, and it could be wedged between the two columns and could get a stable intraoperative fixation, and this is the follow-up. So how often does open reduction and internal fixation of geriatric acetabular fracture lead to hip arthroplasty? This seminal paper showed that 1-year mortality was 25%, and rate of conversion to arthroplasty after ORIF was 28% at 2.5 years for the geriatric age group, and which is led us particularly because the Indian patients are more morbid with lesser life expectancy. We have published our work frequently. This was the acute total hip arthroplasty in elderly, where we used the octopus cage, which has since been discontinued. But then this will always allow you to sort of restore the bone stock and restore the center of rotation of the hip. With the availability of modern multi-hole, modern porous metal cups, it has become easier, if you like, to fix these fractures and the problems. And very often we would use an additional plate for acute total hip arthroplasty. In these cases, the 56-year-old male with acute fracture dislocation right hip, and again, modern porous cups could be used. Another case of polytrauma had a fracture of the distal femur on the same side, and the acetabular fracture on the opposite side. So we have published our results of acute total hip arthroplasty using modern porous cup. 18 patients, we used the Regenex cup, which has now been discontinued. 48 months follow-up showed excellent results. If we have a acetabular fracture in elderly, particularly in Indian scenario, a comorbid with high risk for surgery, where you want to do one surgery to get him up and about immediately, to provide adequate fixation and early mobilization. So this is an example: acetabular fracture with severe combination, not amenable to reconstruction. We use the cup cage construct. We use the trabecular metal shell. We remove the ring so that it allows us to put the screws at the very periphery and to get the hold into the bone where it's possible. And then, because we don't have the original cage available with us in India, we use a Schneider cage as an innovation, and then we put in a liner and then put the whole lot of bone here to restore the bone stock. And this is a follow-up of the same patient. 72-year-old female had acetabular fracture with acute pelvic discontinuity. You can see the head was actually quite damaged, did this surgery, and it dislocated. Now, this is a very depressing scenario, but not at all rare. The bony landmarks are actually quite compromised in complex fractures. It's easy to put the components in bad orientation, and then of course sometimes there's an atony of muscles or the injury to the muscle neural supply. So we did close reduction and give a hip abduction brace. So we have published our series of cup cage construct using porous cup with Schneider cage in management of complex acetabular fractures. And in 8 patients, we had 1 dislocation. This is another case operated previously, early fixation failure, and we did the cup cage construct. Surely enough, it dislocated. 2 attempts were made at close reduction, and then we had to revise with a constrained liner. So I started with cementing a ZCA 28 millimeter head in the cup cage, went on to constrained liner, then went on to a trilogy acetabular liner with 36 millimeter head, because you won't get the 36 millimeter cemented cups, and you could get them in as small a size as 50 millimeter. And then we moved on to the dual mobility. So quick word about the cementing dual mobility in this cup cage construct. And this is an example. And you can see the dual mobility cup was cemented. So we have our own series of cup cage construct with acute pelvic discontinuity, 26 patients. Initial 12 we did with ZCA and trilogy liner. We had 2 dislocations. And the last 14 cases, we have cemented a dual mobility cup without any dislocation and 100% survivorship at 2 years. So this is a paper in which we have written about our experience and recommendations. To summarize, total hip arthroplasty in acetabular fracture is a challenge. Infection should be ruled out. It needs meticulous planning. And the challenges are hardware, obtaining long-term acetabular component fixation, and making sure that the risk of dislocation is low. Thank you very much for your attention. And I would now invite Dr. Vivek Trikha for a complex acetabular fracture case presentation. Dr. Vivek.
Yeah. Thank you, sir. Okay. So now we go to a complex case in the acetabular fracture. He was a 26-year-old soldier, had a motor vehicle accident when he had come to his hometown. And he had this sort of an X-ray with which he came to us, had a fracture of the acetabular region. And also he had some injuries to his knee and one of his elbows. So it looks like a complex fracture of an acetabulum involving both the columns which we can see. Once he was stabilized, we got his other X-rays done. And these were his inlet, outlet, and obturator views also, which you can see. This is his CT scan, the two-dimensional CT scan. The axial scans, where you see that there is a lot of combination, especially where the columns are broken. Both the columns are broken out there. And there is another component or a combination component out there. Along with that, what we see is that there is also a femoral head fracture, which we can see out here. If you look at the coronal images, again, we see that the head fragment is also a big fragment on the first ones. And also there is a lot of combination at the acetabular column region at the quadrilateral plate where this fracture has happened. And this is what we see in the CT scans as well. A femoral head fracture along with most likely a dislocated hip, a subluxated and dislocation of the hip joint, and the femoral head lying outside on the posterior aspect with combination and probably a T-type fracture of the acetabulum. So any comments regarding this diagnosis as well as the fracture pattern?
I mean, that's a tough problem just because you hate to see a femoral head injured like that. And you can really see it pretty clearly in your upper left image. You see that
yes, exactly.
hearing injury, which you saw in the initial film as well. Yeah, I mean, I think you have to just. How old was the patient? I missed that.
He's 26, a soldier who has come back to his hometown for his vacations.
Yeah, so you're gonna want to fix this. If this was a 70-year-old, a 65-year-old with that femoral head injury, you may be looking at a primary arthroplasty, I think, in preference. But for a young patient, I would move to fixing this. So I think, when I look at this, and it's a very quick look, but I think your best reads, as you can see on that middle image at the top, is sort of your anterior column, right? Your anterior column is your best read. So I think I would probably approach this with a dual sequential approaches. I think there's a lot of options here. Mm-hmm. There are people who would go directly to a lateral approach with a flip, and I think that's the other way to do it. But to me, that although it gives you good visualization of the anterior column, it doesn't give you a lot of ways to reduce the anterior column. So I think I would probably go to the front. I would do the anterior ring where that really good read is and get that back in place. So I'd have something to work to. And then I'd go to the back and I would do a trochanteric flip with a surgical dislocation to fix the rest of the joint and the femoral head. But I could see doing this 10 other ways, right? This is terrible injury.
So let's ask Hassan also his opinion regarding how he's going to approach this fracture.
Yeah, I think I'd probably just go from the back from the start and do the trochosteotomy, because I think that if you go from the front and you do that stage and I agree with Paul that's the easiest reduction. But then if you can't get the hip reduced, and if you have to stage it on different days, do you really want to leave the head out of the back, and et cetera? So I'd want to get the hip reduced. And I think that with the hip dislocated, you can actually get the anterior column reduced pretty easily with the head not in the socket. So I would probably try to do this all from the back.
Okay, so you will be going all from the back in the initial stance, and you are expecting that you will be able to fix the anterior column also from the back with the troch flip osteotomy.
Yeah, I think that especially with the troch flip and the head still out of the socket, you can actually manipulate the anterior column and get it reduced and possibly fix it with an anterior column screw, and then not have to do the second stage in the front.
Okay, so do you do that?
So Hassan, are you going to do a surgical dislocation, or are you just doing the trochanteric osteotomy to give yourself more anterior exposure?
Probably. So I'd want to plan it more, but I think that it's already dislocated. So if you can get the femoral headpiece out with the hip already sitting dislocated, I'd probably try to do it without messing with the troch at all. But then if you can't get it and can't rotate and reduce, then yeah, I'd probably add the surgical dislocation. I think the capsule here is torn. The posterior wall it looks like another piece. I think that you're going to be able to see the whole head from the back.
Okay, Dr. Anybody else would like to comment? If not, then what I would like to ask both you, Paul, and Hassan is, which is the fragment would you like to fix first? Because I thought that maybe, would you like to fix the femur first or the acetabulum or the femoral head? If it is lying dislocated, you might as well fix the femur first. Do you think that will be a right option, or we go in for the acetabulum first?
Yeah, I think so. I think if you're doing it the way I do it, which would be to get the sure thing first, right?
Right.
So if I get the sure thing first, which is in the front, that's a very easy operation, and it's 100% predictable, and you're going to be able to dislocate out the back irrespective of what you do in the front if you choose to do a surgical dislocation, right? So I'm not worried about having trouble with that. And I wouldn't do it in separate days because the front takes, it's a half hour, right? Half hour, 40 minutes. If it's a quick operation, and then I would turn it and do it the same day. I might even do it just in the lateral position. If it was a small patient, do it in the lateral position, do the anterior approach lateral, push that down, and then just go right to the surgical dislocation. So if I'm doing it that way, I would do the anterior acetabulum first. Then I would do the hip, the femur next, but I would do a surgical dislocation if I had to. And I think I would have to. I don't think that I could manipulate those intra-articular fragments well without seeing the joint well. And when you have a hip that's dislocated posteriorly, while it sounds great, you can't see anything in the front.
Exactly.
So although I can't, maybe someone else does a better job than me, but I would have to strip too much. So to me, I would have to do a surgical dislocation to do it. And then the order doesn't matter. Sometimes with the surgical dislocation, having nothing in the way and not fixing the head, the acetabulum would be easier to fix at that point, but it makes no difference what order you choose if you've done a dislocation. You can do it in either order, and it's basically the same thing. If you're doing it from the back and you're trying to keep the hip dislocated and somehow be able to kind of see around it, then, fixing the hip second would make sense because you'll have better visualization before you put the piece back. But I just don't think I could do that. I don't think I could do that. I don't think predictably I could do it.
Because if you see that the posterior column is broken and is widely displaced out there. So even if we are doing a surgical dislocation beforehand, where exactly it is going to stabilize, we are not able to see anything out there. And your reduction as such and stability pattern is also difficult.
Right. And you can clip the posterior column right through the cochlear portion of your surgical dislocation before you do your capsulotomy or dislocation.
Yeah,
so
exactly.
You can definitely do the column first, but I wouldn't definitively fix it because the advantage of the dislocation is to be able to see the joint. So clip it, maybe a lag screw, something simple, a little push plate, but I wouldn't do formal definitive fixation.
Okay. Hassan, anything further? Any more comments?
No, I mean, I think that it likely would require the surgical dislocation from the back. And if you're doing that anyway, then I just think that your anterior column is not going to be that hard to reduce from the back, even if you've done the dislocation. So
right. So this is what we were discussing, the approach for the acetabulum and the femoral head, which one to tackle first and the sequence. And as you said, Paul said that you can tackle it whichever way you want. You have got all the fractures which you want to fix. You can go anterior, you can go posterior, you have the femur. So whichever one you want to fix, you can have it as it tosses. So my plan was something similar to the posterior part, I would say. I normally keep, whenever I have this fracture, complex fracture, the best thing is, what I do in my thing is break it down into simpler constituents and then treat them one after the other. And that's what we did, keep it simple procedure. Because it was a dislocation of the hip of the posterior side, along with the more displaced column, which I thought that should be able to reduce it initially as early as possible. So that was the first thing which I thought I will be doing with reduction of the hip and tackling the most displaced column. Once I get a stabilized posterior column, then I can fix the femoral head through the same exposure. If required, as I said, flip osteotomy. And as was there that if my reduction of the anterior column is anatomical out here, then I might go in and put in and fire in a screw out there when I'm seeing it. Else, I will go and reverse the procedure and go in again with a lateral window with an ASIS osteotomy and fix in my anterior fracture. Because what was worrying me was the comminution at that area. If you see that where the fractures are held, both at the anterior as well as the posterior column, there is a lot of comminution and flake of bone. So that I wanted to visualize it right in front of my eyes to get that I'm able to get the accurate reduction. Because here for me, there was no chance of inaccuracy, even a minor one, because that's 3 fractures which we are dealing with. And even a minor discrepancy on one side is going to exaggerate the things, and the functional outcome is going to. Remember that we are dealing with 3 fractures out here, which can have a direct impact on the functional outcome. So that's the thing which I would like for the audience to also remember, that we have to keep it, break it down, make it in the best way possible. So this is what we went about in a lateral position. If we see, this is the greater trochanter. I removed the fragments which were there or which we needed to with the small intra-articular fragments, the posterior and the cephalad way, reduced it, and then went about fixing my posterior column after the reduction. You can see that fracture is there with the ischial spin, standard ischial tuberosity, the reduction of the posterior column. How is it done? The same way I tried to derotate that fragment, was not able to get that displacement properly reduced and compressed. So for that, use the Farabov procedure. Again, the same principle, the simple how to do a posterior column. And once I was able to get that adequate compression of it, then the fixation was done. I fixed it beforehand, made it into now a fixed posterior side. And since it was already there, I did a flip osteotomy now and fixed it. This was the reduction which I got. I was able to get an anatomical reduction of the posterior column. So once I was happy with that, I fixed it, then converted it into a pure cochlear or a flip osteotomy fracture with a femoral head fracture, and with a surgical dislocation, saw this fragment which is there. Reduced it and put in some Herbert or HCS headless screws out here. But what I want to ask from you people out here is, many a times when we have this femoral head fractures, we see this sort of an abrasion of the articular cartilage on the media, on the side. And mostly you cannot see this fixation of these screws is best with a flip osteotomy and not through KL, because that exposure of that area is not there. It is infero-medial, antero-medial, inferior part. So what, I know there are osteochondral grafts or fresh frozen, but what do you do in your practice regarding these big abrasions, and which are just abrasions on your acetabular cartilage? What is your experience in this? Paul, Hassan?
Yeah, frankly, I don't have a lot of experience doing. I mean, I think we've done 3 or 4 surgical dislocations for acetabular fractures. Like, it's just not a common operation for us. The times when we would do it is if there's a femoral head injury with sort of a small posterior wall. This would be a great indication for it, like I said, but it's an uncommon problem. So I would drill it, and we haven't done anything more aggressive like putting acute osteochondral fragments on now. If it's salvageable, and if it's in the roof, that's a different question, right? So if it's in the weight-bearing surface, that's a little bit different. This looks like it's not quite reaching the roof, although it's hard for me to get the orientation not being there. But it seems like the roof is more to the left of the interior, right? So that area looks pretty good to me. So I think if it's in the roof, you've got a really big issue, and then you may consider it. But if it's more on the side of the head, I wouldn't
leave it like that.
About it too aggressive at that point. Okay. But I can't say that I have a lot of experience to say that's the right answer.
Hassan, your experience in this?
Yeah. So again, I'm similar to Paul as far as fixing femoral heads with surgical dislocation. I've done a handful. I fixed most of my femoral heads from an anterior approach.
Yeah.
And so you can still see that the cartilage is sloughed from the front. But as far as what to do with it, I've drilled them just because it makes me feel better. I don't know that it actually does anything for the patient. And then certainly my discussion with the patient is, hey, your cartilage was torn up, so you're likely to get arthritis in your hip in the future.
But in this case where the posteriorly we had to go for the posterior, I think doing a troch flip was a natural further thing which we could have done.
Yeah, it's very, very good plan.
Yeah. So the next thing was I would try to get my reduction, but was not able to get the accurate reduction of the anterior column. So as I said, I wanted to get the best. And as Paul said, it is just 45 minutes for an anterior side to just fix it. And this is what we fixed it through with lateral window with ASI osteotomy. And what I want to show out here is that this is the beauty of that if you want, you can put in your plate so medially before lateral to the iliopectineal eminence and the iliopectineal fascia, with the psoas acting as your cushion against the vessels and the fascia, that if you want, you can put in 1 or 2 screws even medial to the hip joint and give it stability. If you don't want to put in your anterior to anterior screw, I put it here both, and as was able to get with that plate, the combination was able to be properly reduced. Anterior column was reduced, and then 1 screw going even medial to it on the hip joint, which gives it sort of a bone clamp sort of a thing fixation, which I was able to get. Yes, dual fixation, but it is hardly a morbidity, I would say, because it's a small operation. Is finished within 45 minutes. We can get that. This is his X-ray after 2 months. You can see that ASI osteotomy. So I think I can fix those ASI osteotomies, Hassan, and the trochanteric flip as well. So what we find out here is this heterotrophic ossification. And that brings me to the next question, which I would like to ask from all of you. What is your preventive method? Is there anything which you would like the audience to know how to prevent this heterotrophic ossification in such a complex injury, and for that matter, even in a small injury as well?
Yeah. So I don't use any radiation.
Mm-hmm.
I don't use Indocin anymore either. I just do an aggressive debridement of minimus, and then even some medius at the end of the case. So at the beginning of the case, I'll take out a lot of minimus to help visualization for reduction, etc. But then at the end of the case, I really also look at the medius, and if there's some medius that looks really bad, I tend to excise it as well.
Okay. No radiotherapy.
It's a really good question, and if you look at all the statistics, right, it's the things that correlate basically are all the things that say that the posterior musculature has been damaged, right? So it's T-shaped fractures, male gender, displacement, posterior approach, like everything adds up to the same dislocation. So, this is a muscle reaction issue, as Hassan alluded to. So I do a very similar thing to him, is that I do a lot. I actually do a fair amount of medius debridement. The minimus comes out. People say they do the minimus debridement, but really that's just like getting the exposure, right? So I think it's just part of the exposure. But I do, I use a Charnley retractor, and I take all of the dead medius and all of the questionable medius. It's not that much, but a centimeter on each side, I take routinely. A while back, Joel Matta did a really nice study of Indocin and looked at 3D CAT scanning to look at the volume of heterotopic ossification. And it didn't seem to be different with Indocin, but it was a little bit lower, but not statistically different. I have seen, a couple of patients in my career, which I did all the same surgical stuff. And I've only had 2 really bad HOs, one that I resected when I was in New York, and one here in Boston. And both of those patients didn't take Indocin, even though I prescribed it. So the downside of the Indocin is just the GI upset and bleeding and things like that. And I still give it because I think that the risk of giving it is very low. And I'm unconvinced, based on the power of the study and the statistics, that it's not helpful. There was just a recent study of looking at I think your guy Quaid did it, right? San, the guy who trained in Tampa, looking at hemostatic application and showing a lower rate of HO with that. And I've actually started to incorporate that. So I think that was a really nice study, because they used it for something else and found like this accidental covariant that seemed to be helpful. So I think that's something people should consider as well.
Yeah, that Surgicel or things like that, which you are.
Surgicel.
I think that's very important discussion, and we operate on a lot of ankylosing spondylitis patients where they're at a very high risk for developing HO. So we have routinely used indomethacin, and it's pretty safe. I would not radiate a young male. I'm quite reluctant to do that. But I think the key points which have been highlighted already are not leaving any dead muscle. They are removing minimus right at the beginning, debriding any dead tissue, not leaving hematoma there. So I mean, that is known to give rise to the problem and the reason, and hence the utility of hemostatic agent. And we also give it a good wash, to prevent any debris being there and starting eliciting any this thing. And really, we have not seen a very significant heterotopic ossification. Vivek, what about you? How many Yuri Brooker 3 or 4 serious severe HO you have seen?
No, we have seen quite a bit, because most of our cases are polytraumatized with head injury as well, and many of them are having. If we are operating on them with a Cocker-Langenbeck. And the other thing which I see and which I would like to ask also is that most of our HO which we find is going anterior, which is for the minimus part. Anterior. If you get a CT scan also, it is going from the inferior iliac spine and that region towards the anterior, where the gluteus minimus is going and attaching. And that we are debriding mostly from the posterior aspect where the injury has happened. But as you would see here also, if you see a lateral view, if you can see this lateral where the reduction of the posterior side is okay, but the anteriorly you are having that heterotrophic ossification. This was his 6 months follow-up, and he had some knee issues as well, as you could see, and there was a calcification with the medial condyle pellegrini stridus sort of a thing, which was not having his knee movements, but you could see that he was able to flex his hip and do an abduction of the hip to a great extent. At 1 year, he is having a HO of this much. And you could see that, as I was showing and asking you, it's on the interior aspect, mostly on the interior aspect, because the medial and the central aspect we have all debrided. But how interior you go is the question for debridement. And at this moment, my next question is, if you need to do an HO removal, what is the thing which you are going to look for? Do you look for that maturation or a cold or hot thing, or you just go and debride it?
Yeah, I've done only, so again, my experience is limited. I've done 2 HO removals in my life. Both of them were much more significant amount of bone than this. Like they were a fair amount of, and one of them, I did the same thing. I had to get a CAT scan to understand exactly the anatomy. And one of them, the sciatic nerve was going through the freaking bone. So I ended up having to find the nerve at the notch. And then, I think it took me 6 hours to take out the bone, 3 of which was chipping away everything next to the nerve, because it was contained in about 3 centimeters long of a tube of bone. Like it was just completely encased. And that was very unpleasant. And the patient didn't lose function, but it was really, I was scared to death, honestly, when I was doing it. And then afterwards, I do radiate those patients. So I put them in the obturator oblique position. I go over to the RT place myself, and I put them in a position, get an X-ray, and I draw out on their screen where I want the radiation to be, so they don't actually get the hip, because they don't do a lot of it. So, it requires your own personal intervention to walk your ass over there and do it. But that's been my, very limited experience. And neither of them came back, but I gave them both a single shot of 600 gray and indomethacin. I don't know if that's the right thing, but that's what I did.
Hassan, what about head injury? I would like to ask you guys, that's a real problem, isn't it? We get very florid heterotopic ossification in polytrauma patient with head injury. And do you have any special tricks up your sleeve, something you do in your center?
Yeah, so that's the one where, my experience with HO excision is actually half of Paul's. I've only done one, and it was also a miserable experience. But what I do, especially in head injured patients, is a lot of times, as the attending surgeon, you're kind of there for fixation, and then you may want to just kind of go while your fellow or resident or assistants close up. But I make sure I stay beyond fixation and actually stay there, especially with a head injured polytrauma patient, to do the debridement of muscle myself, because I feel that sometimes more junior colleagues will be less aggressive with that muscular debridement at the end. So I in particular with head injured polytrauma, I stay and do that muscular debridement myself and make sure I'm part of it, to make sure it's that I feel comfortable with it.
Well, great. I think, gentlemen, we have to move on. Do you have anything else?
I'll just finish it off by saying that, yes, at 3.5 years, I had not gone for an HO removal out here, because he was fine. You could see that his range of motion had improved. He was able to sit cross-legged and squat, even with this amount of Brooker classification, grade 3, grade 4 sort of a classified grade. He could abduct. Even he could externally rotate both his limbs. The only problem was his internal rotation, which he was not having. You could see all the movements of his. classically only internal rotation is not, and he said, I don't have any problems with this. I don't want any further surgeries.
Yeah.
And just to,
I agree.
Yeah, that's a really great result. I'd ask Dr. Malhotra what you think about that hardware and HO for your future total hip.
Yeah, I think that's a terrible thing, to go through that HO. I will possibly radiate that patient if I do HO, if I do total hip in that, because one of the risk factors for HO is when the patient has already existing bone there and you go and remove, and those are the cases who will need radiation definitely.
Right. Thank you. I'll just finish it off by saying that in the end, the take home for this is that in a complex injury, proper planning and knowledge of the fracture pattern, keep it simple, approach the injury step by step, maintaining your accuracy, good results with right approach and anatomical reduction, but you always counsel the patient for achieving the best outcomes. Thank you.
So now I invite Paul for the complex acetabular fracture cases. Paul, the stage is yours.
You're unmuted, Paul.
That was helpful, Hassan. Thanks. So first one, I have two cases. The first one is basically healthy, somewhat larger individual, MBA, had a chest injury, but no real problems with oxygenation. He's stable, no bowel bladder. He had an acetabulum and a both bone with no compartment syndrome in his forearm. So this was his presentation AP. And I present this just for the discussion around sort of clamp placement and predictable problems. And not that this is a highly complicated problem. It's a basic transverse pattern, as you see, but when you see the SI joint off, you have to be very careful. So I've seen people miss that, because once the hip gets reduced, the SI joint looks better, right? So here you can see presentation AP. So, initially we put it in traction. I think that's a good idea. I'm not sure if anybody else uses angiography. If someone has a problem that goes into the notch, we get a CTA when they go through, but this one didn't get it. And I don't think there's any real urgency to it. So we put a traction pin. The SI joint still looks a little bit wide. Sometimes these, though, will look really pretty good once the hip is reduced. And I think that people get tricked into doing these like in the prone position, the SI joint opens and then you can't get your transverse reduced. So people who do them lateral or supine are probably in a little bit better shape. This was just the both bones that we also fixed. So here you can see the plain films. It's a sort of a transtectal transverse. It's more oblique than most, coming out a little bit more inferior at the bottom. So here's the SI joint, and here's your dislocation. I mean, your transverse. So I guess I'd ask, what approach would people use? Do you do the SI joint first, same time? Do you do it extended? Do you flip? Do you do an ilioinguinal or a stappa? Dual approaches? What would people pick for this basic, transtectal transverse, very oblique with an SI joint?
Can I? In my hands, I would like, if it is a very high fracture, these are transfers which are very high, the transtectal ones or the top ones. I will like to go it from an anterior approach and use it with an ASIS osteotomy, using this, not just the lateral with an ASIS osteotomy, combining it with Smith-Peterson sort of a thing, so that I can medialize my psoas much more. It helps me to get that rotation, the external rotation of my iliac fragment back into its place properly, which I can visualize from my anterior visualization of the SI joint with a shank spin or a iliac crest or an AIAS shank spin, which I can derotate it. And then I can put in my plate, as I showed in my talk also, and fire in 2 screws from the anterior to the posterior one after getting with a collinear clamp, maybe putting in this. So that is, I don't normally go anterior for transverse fractures. I normally go posterior because that's what is the common approach for a transverse. But for this fracture with a high column, both anterior and posterior, I tend to go anterior nowadays with an ASIS osteotomy combining with Smith-Peterson.
So I would
that will help you address the sacroiliac joint as well.
Yes. with the reduction as well as the screw fixation if required.
So I think either supine or prone, I would certainly fix the SI joint first with a percutaneous screw, which it would be easier to do supine because you wouldn't have the deforming force of on the ilium. But even prone, you can probably get it with a percutaneous screw. I think that the piece that worries me a little bit, and the fact that he has bilateral both bones, or even if it was unilateral, that you want to probably address, I'd like to do it supine, which means I would probably go from the front just to get everything done. There's on a few different views, there's been a free piece that I can't quite figure out where exactly that is. So yeah, so that piece, I would want to kind of study the CT more to see how big that is, if that's something I'm going to go after to also try to address.
You mean this here, Hassan?
Yeah.
So yeah, you didn't have the advantage of going through. That's actually just part of the roof that's attached. That's attached to
okay, so it's not a separate fragment?
It's not. Yeah, it's not. I'll just tell you, it's not a separate fragment.
Okay,
but I had to do that same evaluation. Yeah, I had to do that.
If that was a separate fragment, if that was a separate fragment, that would really probably drive my decision a lot more hand than where is that fragment, so I can access it and fix it with a separate intra-articular implant. But yeah, so I think you could go either way with this, prone or supine, fix the SI joint first to then be able to reduce the transverse.
Yep. So I agree. And my choice was do the same time, do ilioinguinal. I think I could do a Smith Pete with with an osteotomy as well. I'm really comfortable with the ilioinguinal. It didn't take me very long. But what I point out is that when you have these, exactly what you said, Dr. Tricka, that all the transverses I do, prone, the one I do supine is when you have a transtectal with a high obliquity. They're very difficult to do from the back. That's actually the pattern that Laudernell recommended doing, transtectals through an extended approach, which is why I put the flip in there as an option, because he felt it was so important to get the roof of the joint perfect that they did extended iliofemorals for these as a routine. So I've been pretty happy doing them from the front. But my issue is, whenever I try to reduce this over, you're pushing over on the SI joint. So you've got to get the SI joint first. I think a screw in the front of the SI joint makes very little sense. So I just plate it, right? So it's a type 2 injury. You put a screw in, you're not in the correct corridor unless you put an Ayler screw in, which makes sense, but I don't really like doing that. So those are sort of the problems that I see. So I go for the SI joint first. So I'm doing that upper window anyway. So I just put a little plate on the front of the SI joint. It takes about 5 minutes, and that's very easy. And that locks in your rotation. So now you can get your reduction. So that's my own personal preference. And then I'm going to try to get this transverse reduced. And again, you've got this plane. And the problem when you put a clamp on and push it this way is it tends to slide. So these very oblique ones on the AP radiograph with that quite vertical axis, you put this clamp on or a collinear clamp or something else, and you can see that fragment that Hassan was talking about is now lateralized compared to the roof what it's supposed to be next to, right? It's shifted this way. And that's a tough thing to control through just an anterior approach. Like if you're in the modified stappa, the AIP, you're just pushing over, which makes it worse. So this clamp, to me, I always end up having to put a second clamp. So this is where I like the ilioinguinal, because it's very easy for me to place this clamp to compress the fracture this way while I'm compressing it over. And that always enables me to get a perfect reduction. Whereas when I do this through anything besides the ilioinguinal, I feel like I struggle a lot more. This is a pretty quick step, and then you can get an accurate reduction and you can place a percutaneous screw. And you can see that how these things are bent. The amount of force to reduce that accurately to get it line to line is actually quite a lot. So I show it just because I think that while the fracture is not that complicated, the deforming forces actually present a fairly difficult scenario. And then I did the same thing you did. I put that little plate on. I lagged into the posterior column as well, as you can see here. And this was sort of the final post-ops, and he went on to do pretty well. But I think it's an interesting pattern when you have these combination injuries. Any closing comments, Hassan or Dr. Tricka? Anything that? How do you deal with that from the AIP? How do you deal with that compressive? Do you put a different clamp like on the inside to compress, similar to what I did, Hassan, or do you just add it?
I've actually used a fair Bluth, a young Bluth through the AIP. It's not easy, but you can do it. But
Yeah.
it helps prevent that shear.
Yeah, so
I think
you're double clamping it as well. Then you're basically clamping it superiorly and then across.
Yes.
Yeah.
if you do an ASIS osteotomy or a Smith-Peterson, that fragment which is there in the roof can be very, and the anterior wall area, you can see it very properly, because that's how you look for your femoral head
Yep.
fracture.
Yep.
So I think that a lateral window with a Smith P combined with an osteotomy is going to give you that entire exposure of all the dome area which you want here. And maybe if you want another clamp from that place, we can still get it. So I very usually used to use ilioinguinal, but for many of these fractures, because they are so lateral to the iliopectineal eminence, that now many of these fractures I feel like still can just come out with osteotomy and Smith P and not go through the inguinal ligament.
Right.
And
So your second clamp would just be on the anterior part of the acetabulum under direct vision.
Yes.
The key is, so there you have 3 surgeons doing it 3 different ways. But again, that's perfect, because the principles for all 3 approaches, right, are the same. You've got to get compression as well, superior to anterior as well as medial to lateral, and that's what people don't recognize. So that's good. That's good. So here's a little more of a bad case. So this is a 52-year-old, really pleasant woman who had this injury. So I'll let you look at that for a second, because it's not a quick evaluation. And here's the oblique. So it's obviously a both column, but also there's an iliac wing fracture, right? So it's not isolated to that. With a lot of comminution, a separate posterior wall fragment that you can see, and a lot of medial comminution of the quadrilateral surface. And I show this just, you can see a separate roof fragment there that's like in Nowheresville. So, I'm not saying I do a lot of these. Like, this is one of my 5 worst things I've ever dealt with. So it's not like, oh, he does these all the time. Nobody does these all the time, I hope. So here's the CAT scan, just sort of showing what we're talking about. The SI joints, thankfully, I thought were okay. That looked a little funny to me, but I wanted to evaluate it. And here you can see these separate fragments, separate roof fragment, separate posterior wall fragment, all of which are not large, with a tremendous amount of comminution. I think it's similar to the case Dr. Trickey you showed, but a little more intra-articular comminution. So here's the 3D to give you sort of an idea of what we're dealing with. Now she's 52, right? The other thing is a segmental posterior column, which makes things exceptionally difficult. And you can see that separate roof fragment through the fracture site there. So what do you guys think of that?
Yeah, so obviously a highly comminuted complex both column with, the segmental posterior column is just, it's so hard to deal with. If it's just a both column fracture that happens to have a wall component, I don't worry about that as much, because it's not the same as a regular posterior wall, right? And you can try to actually capture it and get a screw in from intrapelvic to capture it. But the segmental posterior column makes me think, with this, if I'm truly going to try to get it anatomic, it's going to have to be front back. So I'd probably start with front with AIP lateral window, try to reconstruct the anterior column, try to get the dome segment back best I can. And then likely we'll end up having to flip prone and go from the back to get the posterior column and that wall.
So in a 52-year-old, would anybody be considering a primary joint, reconstruct from a, whatever anterior approach you like, and then do a total joint in a 52-year-old? What are your thoughts? What does everybody think?
The damage is severe enough to warrant. However, I think with what is more important here is equally important, I would say, is to fix the ilium, because I think in many cases I think it's preferable to start restoring the anatomy from where it works the best, and in any case to deconstruct the entire acetabulum, start fixing from the ilium and fix anteriorly. And I think even if you wanted to do a primary total hip in this, you would have to fix the fragment. It's not something which I would get away with the cup cage. I think I would need the fracture to be fixed, and if the head is too damaged, put the plates in, and then do a joint replacement. So fixation has to be done still.
Yeah. Dr. Trucca, any
the same thing. I'll go anterior whichever way. Stopa with a lateral with a ASIS or osteotomy. That is going to help me again fix that crucial dome fragment. I'll reduce the hip first. Once I reduce the hip joint and get my ASIS or anterior inferior spine bone, which is the dome bone proper, then I'll see whether my reconstruction is possible or not, because that fragment of the dome is a small one with a major fragment of the anterior inferior spine. Once the femoral head is back to its place, it may fall back for me. And then I just have to do a ilioinguinal or a stopa with a lateral Smith P and fix it with things. So posterior segmental, posterior column will be tackled later. I wouldn't have done it as Hassan said, but because it's a column with segmental, I might not put in screws from the front. I might have to go from the back.
There is likely to be significant head damage as well. I mean, Paul can tell what.
Yeah. I mean, I wasn't worried about being able to evaluate that. I figured as soon as I opened it, I'd see the head. So I figured I'd know the answer to that pretty quickly. This was. I mean, honestly, I lost a lot of sleep thinking about this patient. I explained to her, look, I think there's so much damage. I don't expect that I'm going to be able to get it anatomic. I honestly didn't think I could do that. And I told her that we were going to restore bony stability, get the best we could, and that she would likely need a total hip within a few years. And we're going to do everything we could to avoid creating a situation where that would be difficult. That was sort of my own view of this injury because of the level of comminution. So these are all the.
Yeah, I mean, the other thing I tell my trainees with this is that, this isn't going to be our standard fixation construct. There are going to be a lot of little plates in places, and you're going to have multiple plates, and it's just going to look like a hardware shop when it's done.
Yeah. So, and this was the added bonus, is that she had a big Morel Levelet. I know I saved that for the end. So I had planned not to go to the back no matter what. Right. That was sort of the plan, was to figure out whatever I could do from the front. And I wasn't going to go to the back because I had just deathly afraid that if I went in here, debrided, did everything, that if it got infected, then she's got no recourse. So now you're restricted to just the best you can do from the front, which again was one of the reasons I lost sleep. So, again, the femoral head's pretty easy to see. And surprisingly, there was not a lot of damage on the head. I was shocked to see that the head didn't look terrible. I'm sure there's, some cell death, but so I did as you said, Dr. Malhotra, I went to the back, and I always start at the iliac crest. Also, that was the only thing I had any confidence that I could reduce. So I felt pretty good about that. And you can see that, that separate roof fragment still, even on these views. So we went to the crest and then sort of built back. So here you can see some crest fixation, some clamps. You still see that roof piece is not quite right. That's a clamp. I mean, that's reaching around the back, just like Hassan, what you said, you can oftentimes get to the posterior wall through that approach. So I reached around the back. Luckily it didn't get into the hematoma, and was trying to just kind of push that down and get it reduced so I could capture it somehow. And we eventually got it, I grabbed it with like a K-wire and pushed on it. And I don't know, I felt like I was trying to reduce a fracture dislocation of the talus, where I'm not sure exactly what I did at the end, but it sort of looked better. So some kind of magic happened and some luck came in. Maybe she's just a nice person. But we got it to the point where I thought it was reasonably good. And there you see that vertical posterior wall. And I agree completely with Hassan. These posterior walls associated with both columns are vertical, and you can usually lag them from the front or even slide a plate down from the back and then put a perk screw across, but you don't need to do a coker to get to it. So it started to look a little better at this point. You can see a lot of pushing and pulling. Everything that you see that looks like a pushing thing is just me sweating more and more throughout this. So then we finally got that looking okay. I got a K-wire in it and held it. Then we started to work a little bit through the AIP portion of the approach. So this is an ilioinguinal, but I extended to the medial window. I usually do not use the medial window in an ilioinguinal, but here we went that way, and it's basically the same as an EIP. Then we finally got some fixation into the back that was stabilizing the whole thing. And just like Hassan said, little plate here, little plate there. Let's push on this. Let's push on that. And, this is about 9 years ago now. And this is what we ended up with sort of on the front view. Here's our post-op. I'm not sure, is that enough hardware? It's on probably good enough pieces.
That's
everywhere.
why I tell my trainees that before the case.
Yeah,
So
absolutely. Absolutely. But, you know, given this, I think the roof is maybe a little bit high at its most medial aspect, but that I really just could not hold it down anymore. I got a good lag screw into it. We lagged the back. I wasn't worried about that. I've not seen those posterior walls in the back shift if you get a lag screw into them when they're associated with a both column. So these were my views. You can see there's that little bit of step in the front. So there's a mild incongruity that I couldn't make any better. Maybe you guys could have, I could not. I was actually thrilled that I thought maybe she had a chance at having a hip. And here's her inlet and her outlet views. You can see we did fix across the SI joint, which was also unstable, but overall I was not unhappy with it. This was her at 2 years. And she, you know, she really didn't degenerate much by the 2 year mark. And I always tell them if they get 2 years and their joint is normal looking, it's going to get probably 10 because that's the Lauderdale data is 2 = 10. So that was ended up what we did. I actually talked to her during COVID in 2019. So she's is 8 years out then, and she was still doing well. Didn't need a total hip. When she came back for this 2 year follow-up, that I got a CAT scan because she was bothered a little bit towards the back of her joint. I couldn't quite understand what was happening, but this is sort of what the CAT scan cuts look like. You can see some of that devastation in the front. I tried to get the cut through the roof there on that third image. It's probably right where that little bit of incongruity is, but it, you know, overall for what she had, I was pretty happy with this. I don't know, any comments or criticisms or thoughts?
Yeah, that's a really good outcome for not going to the back and doing it all from the front and sparing her a total hip.
So far. So far,
so good. But then it's so much pleasant for us to go in there in case she needs a replacement, because I think it's so much, you know, the restoration of the anatomy that won't stop. You know, it's a piece of cake. Thank you very much. I think we still have no questions. So I don't know whether it's a good thing or a bad thing. Maybe people are absolutely clear about everything which we are talking about. So we go on to the next session. And the next session, I would like to invite somebody who has been keeping quiet and has been behind the scenes is my friend, Dr. Vikas Agashe. And he is going to talk about the tips, tricks for intertractable fractures. Welcome, Dr. Vikas. And we look forward to your talk.
Thank you. Thank you. Is my screen visible?
Yes.
Yeah. Okay. So I would be talking about intertrochanteric fractures, some tips and tricks. Essentially, of course, I'll focus on unstable intertrochanteric, and we keep on talking a lot about hardware. And the common saying is unstable intertrochanteric should be nailed. And in spite of a proximal femoral nail, occasionally one would have a significant failure. On the other hand, sometimes with DHS also, people will throw a fit if they say this lateral wall is actually osteotomized and then DHS done, but with fantastic results. So what is the key? What is the key here? What are the tips and tricks to achieve success? And I'll focus more on software rather than hardware. I'll be talking more about the tricks. So the first thing is revisit anatomy, think beyond trabecular pattern. So in addition to the classic trabecular pattern that is described, intertrochanteric region has cortical supports, and the thickness of medial and anterior cortex is much bigger than the posterior and lateral cortex. That's an important thing. And then second is understand the pathophysiology of intertrochanteric fractures. And here I come to the a classic paper by James Carr, published in 2007. And he says that most intertrochanteric fractures are external rotation injuries. So with external rotation, the anterior cortex breaks in tension and it produces a clean fracture line. If the external rotation continues and when you get a complete intertrochanteric fracture, the posterior cortex breaks in compression as you see here and it produces a comminuted fracture. Now this theory is borne out by a study published in 2016. 101 CT scans of pertrochanteric fractures. Of the 61 comminution or cases who had comminution, all 61 had posterior comminution and only 3 had anterior as well as posterior comminution. So essentially the comminution is posterior. Coming back to Carr's paper, so what he suggests is we often try to achieve stability posteriorly, which is not possible. And if you fix the fracture like this, the proximal fragment will displace in spite of a good implant because there would be an uncontrolled collapse. There would be no bony stability achieved and the proximal fragment will continue to collapse and will lead to failure. On the other hand, we tried to achieve stability anterior-medially, whether there is a clean fracture line, there will be excellent bone-to-bone contact, as you can see here, of a good cortical bone, and the implant would give additional stability because you have already converted an unstable fracture into a sort of stable fracture, and the implant gives additional stability, and you will have a very happy situation. So question is, how do you convert these unstable fractures into stable fractures? Several methods are described and we have many simple but useful tools and tricks. The spikes, the hooks, the hooks which are into various angles, the shank screws or Steinmann pins, or even a hemostat. So these crooked hooks can be put in percutaneously. If there is an excessive valgus, then they can be put in on the medial and inferior side. If there is a significant varus, they can be put superiorly and laterally. If there is an anterior displacement, they can be put anteriorly. And if there is a posterior displacement, as you can see here, there is a posterior displacement and one does an intrafocal reduction. So I put a spike inside the fracture site and levered it out, levered the posterior fragment out, and then held it with a K-wire. A hemostatic method was described way back in 2010, mainly for a little lower fractures. But here I have shown it on a bone model. You can see the tense, tight fascia lata, and then against that fascia lata, taking a little posterior incision, one could put a hemostat and reduce the proximal fragment. Shank screws or Steinmann pins can be introduced here, essentially anteriorly. But it is best to hold the reduction with these anterior wires, otherwise they are very likely to slip. A 2020 paper also describes putting it into acetabulum. As you can see, the anterior K-wire is put into the acetabulum, especially in a grossly unstable fracture like this. You can put it into the acetabulum, and this is after putting a proximal femoral nail. But if the reduction is not held with K-wires, I made this mistake. You can see a markedly comminuted fracture, and after I put in a nail, I realized that the proximal fragment has gone way anterior. But it's not all that difficult. You put a spike and hold it and get a good anterior bone-to-bone contact, proceed with the fixation, and this is post-op. as a routine, we start weight bearing immediately. It is very, very difficult for elderly people to do non-weight bearing. This is her at 4 years. Unfortunately, had developed intertrochanteric on the other side. Sometimes there is global combination, as you saw that 3 cases had a global combination. So here, if there is a global combination, if there is an anterior combination as well as posterior combination, medial combination, then what do? Then the best is to disregard the combination and get the anterior and medial stability, whatever it is. So avoid varus, avoid medialization of the shaft like this, have maintained valgus, and just disregard this entire combination, get into concentrate on intact cortices, whatever you have. So here I concentrated on the intact cortices, disregarded the combination, and this is at healing. Sometimes you notice all this, that you have produced a big medial defect, and of course you are worried that there would be an uncontrolled collapse and a failure. For example, here you can see she has a global combination, 84-year-old female. Here you can see there is a significant comminuted intertrochanteric fracture. And then I put in a nail, and then I realized that I have a huge defect anteriorly as well as medially. I agree that my entry was a little lateral. I should have gone little more medially. But now what do? Do I revise the entire fixation? Whether I'll be able to get an entire fixation, a good stable fixation. So just an out-of-box thinking. Can I improve the anterior medial stability? Can I graft this defect? And then I suddenly realized that the graft is just there with me. And I mobilized the lesser trochanter, just cut a few fibers of iliopsoas tendon, mobilized the lesser trochanter and punched in anteriorly and medially. Here you can see we have just punched in, disregarded the lateral cortex, and you can see that's the lateral view, punched in the lesser trochanter to get a good anterior medial stability. Unfortunately, she had early post-op infection. So on 10th day, I explored, debribulated the muscle, the lateral wall. Also, there was some infection underneath the lateral wall. So I excised the lateral wall. But what saved me and saved the patient was the anterior medial stability, which was afforded by the mobilized lesser trochanter. Here you can see at 8 weeks walking very comfortably. We had to start her on teriparatide because her DEXA was very poor. And this is at 9 months. You can see she has consolidated very well, walking as per the pre-injury status for almost 4 months. She has an excellent range of movement. And this is, you can see the lateral wall formed by itself. You really don't need to do anything for this lateral wall, provided you have a good anterior medial stability. And this is at 2 years. You can see very well consolidated fracture. So it was the anterior medial stability that is very important. That is what saved us. So that's the reason why even in good old days, if you could achieve an anterior medial stability, as you can see here, today people will, as I said, throw a fit if this is done. And again, even I would not do this. I would do a nailing in this case with a good anterior medial stability. But this was done almost 18 years ago. And as you can see here, fracture has started consolidating. And this is at 1 year, absolutely consolidated fracture. Coming to some variants, remember there are some irreducible variants of intertrochanteric fracture. This was a paper published almost 15 years ago. The authors described this as a irreducible variant of intertrochanteric fracture. The lesser trochanter goes with the distal fragment, and a spike of proximal fragment gets caught between the iliopsoas and the major fragment, the lesser trochanteric fragment. And different methods are described how to reduce it. very often one has to do the psoas stenotomy to get reduction done. Otherwise, one would get unacceptable reduction like this. I would urge you to read this 2019 paper on predictors and reduction techniques of irreducible reverse intertrochanteric fractures, and they have described various patterns of these irreducible intertrochanteric fractures. Last but not the least, read the brochures carefully, because every implant, there's so many implants in the world today that unless you know your implant very well, you are going to have problems. And today there are very often you use loaner sets, and unless you check the instrumentation and implants previous night, you could run in trouble during the surgery. So friends, to summarize, revisit the anatomy of proximal femur. Be desperate to achieve anterior-medial stability, because it converts an unstable fracture into stable fracture. Simple tricks and instruments are available to convert this. Remember, there are irreducible variants of intertrochanteric, very rare, but they are there. Lastly, as I said, check the implants and instrumentation before, at least a day prior to your surgery. Thank you very much, friends.
Thanks a lot, Dr. Vikas. If you will just unshare your screen.
Yeah, sure.
So I'm going to talk about the fixation strategies for the fracture neck of femur. The learning objectives are how to fix intracapsular fracture neck of femur, the choice of implant configuration, and does the type of fracture influence the implant choice, and the special situations. We know the choice of surgery depends on the fracture pattern, the local factors like bone quality, and the systemic factors. Fixation is preferred in physiologically young patients presenting early without arthritis, with good bone quality and undisplaced fractures, whereas older people with arthritis, low demand, neglected cases, and unsatisfactory reduction need arthroplasty. So options for fixations are primarily the multiple cancellous screws, the hip screw system, the proximal femoral plates, cephalomedullary nails. So, and the most common being the multiple cancellous screws and hip screw systems. So indications for internal fixation are all displaced fracture neck of femur and undisplaced fractures, which are often recommended for internal fixation. Now, if you thought that the undisplaced femoral fractures have no morbidity, think again. They have long-term daily discomfort in 25% and clinical failure in 11%. And it was believed that the cancellous screws can be done easily with low complication and revision rates till the time this paper came out, which said that the revision surgery was more frequent, and it depended on poor bone quality, patient age, and some technical factors. Another paper which showed that the failure rates with cannulated screws was not low in elderly patients, so almost advising against these in patients over 70 years old. And then if you have a valgus impacted neck fracture, it leads to unsatisfactory postoperative locomotive function due to muscle shorting and decrease in the moment arm. So remember that. And of course, this paper said that there's no difference between the non-operative treatment, which had comparable results with the screw fixation. So this is a recent paper. And this paper said that if you have an elderly person and you have undisplaced fracture, you are better off doing latest generation hemiarthroplasty than screw fixation. So you see how the paradigm has been shifted. And this is actually the paper which said that if you have a posterior tilt angle of more than 9 degrees or retroversion angle of more than 13 degrees on axial CT images, then you should do a primary hip arthroplasty in these patients. What about the timing of surgery? This hip attack trial, which my hospital was one of the participating sites, showed that accelerated surgery in less than 6 hours did not lower the risk of mortality or the risk of major complications. And most people agree that if you have a orthogeriatric co-management, then surgery between 24 to 48 hours is actually quite safe. Reduction is the key, and quality of reduction predicts the risk of AVN. So acceptable reduction is neck shaft angle of 130 to 150 degrees or 0 to 15 degrees of anteversion. You should have low threshold for open reduction. You have a whole lot of reduction tools. You can use the joysticks, the Weber clamp, the reduction clamp, the femoral distractor, or the Youngblood clamp. And we are aware of the Gardner alignment index of 160 degree on AP and 180 degree in lateral. The Lowell's alignment theory looking for the S or reversed S on all radiographic views, and where a C curve shows a non-reduced fracture. Now, the young adults are often fixed with cancellous cannulated screws 3 or 4, dynamic or the sliding hip screw or angle blade plate, proximal femoral nail, or the femoral neck system. So this is the plethora of devices which can be used to fix these fractures. There's no consensus for displaced fractures with an equal divide between the multiple screws and the sliding hip screw system. What's the rationale for cancellous cannulated screws? They are most commonly used, easy to insert percutaneously, low blood loss, maintains the bone stock, improves the rotational strength, and maintains the head vascularity. You can use 3 or 4, 7 or 7.3 millimeter cancellous screws. We recommend that they should be parallel, though there's evidence to the contrary. The screw head should be solely within the head. The inferior screw should be on the calcar, and the washer should be used particularly in osteoporotic bone, and you can put them subcutaneously. The inferior screw resists the inferior displacement, while the posterior one resists the posterior displacement. The starting point for the inferior screw should not be below the lesser trochanter, because that will cause a stress riser and cause a fracture. The parallel inverted triangle, and I'm going to talk more about it, is the mechanical stability. So what is the optimum configuration for cannulated cancellous screws? This finite element analysis showed that an inverted triangle configuration has the least likelihood of cutting out and has the maximum mechanical advantage. In elderly patients, the 4-quadrant peripheral screw placement has been described. It's called FQPP, 4-quadrant parallel peripheral screw fixation, which gives good results in patients more than 50-year-old. Whereas if you have a young patient, you can use 4 screws in a diamond configuration, and that's the choice. Now, whether you really need them to be parallel, this paper said no, because it said 3 screws which diverge and lie in different coronal planes, and you can even put them freehand. It gives the enhanced fixation. Now, what about the risk of bony violation? This study was published from my hospital, and it showed that, you know, in females especially, if you use the standard 6.5 millimeter screws, there's higher likelihood of cutout. So if you use one of the 2 superior screws with a diameter of 4.5 millimeter, that risk can be considerably reduced. This is an example of the close reduction and the assessment and the fixation. The posterior comminution must be addressed. So if you have a posterior comminution, you must put a fully threaded positioning screw posteriorly to support posterior comminution. This is an example where the posterior comminution was addressed with 2 posterior screws, 7 millimeter fully threaded, and this is gone on to union with 1-year follow-up. There is an F configuration described, which is the biplane double supported. What worries me here is what I just told you. Such a distal starting point is really a risk of stress riser and a fracture. Now, what is the role of a medial plate for Powers type 3? Now we are talking about the special situations, the very oblique fractures, and this study showed that if you use a medial buttress plate, you have a mechanically superior construct for Powers type 3 fractures, which have been fixed with multiple cannulated screws. There's a concept of a Powell screw, which is a trochanteric lag screw, and essentially it is a screw which is passed in this direction to improve the mechanical performance rather than a traditional inverted construct. And there's enough literature recommending this because it gives added mechanical stability. So you could pass a Powell screw, and this is one of our own cases. You can see the reduction, the intraoperative X-rays, and the Powell screw here, adding to the mechanical stability, and went on to union. It has been recommended that if you are using an off-axis screw, the Powell screw, the purchase should preferably be bicortical. But remember, all these are for highly oblique vertical kind of orientation. What about the fixed angle devices? They maintain a fixed neck shaft angle. There are different various implants within the group. So it's sliding hip screw, proximal femoral locking plates, and dynamic condylar screw, cephalomedullary nail, they have the advantages of greater strength. So they have been recommended for Powell type 3 and the basilar neck fractures. They have a greater ability to resist varus angulation and inferior displacement of the head fragment, and they have the superior mechanics. Disadvantages are they are technically challenging, have a greater blood loss, and may need a separate incision. Now, a lot of systemic reviews have been done. This one said that there is actually lesser complications with sliding hip screw and faster union time, whereas the other systemic review and meta-analysis said there was no difference except that there was a lower intraoperative blood loss with the cancellous screws. In this particular paper, the FAITH trial, they recommended that patients with displaced fractures, smokers, and the patients with base of neck fractures do better with a sliding hip screw. All other groups, they are comparable. This is an example of a fracture neck of femur treated with the sliding hip screw, which of course always has to be done with the derotation screw. A word here, a lot of surgeons are wary of using this combination for undisplaced fracture for the fear of displacing the undisplaced fracture, because the torque, in spite of fixing it maybe even to the acetabulum, like Dr. Vikas Agashe showed, still it doesn't provide enough stability. So this is the 1-year follow-up of the same patient. The cephalomedullary nails have been tried with for basic cervical and Powell's type 3, and this is our faculty today. He has shown that if you use them over patients over 60 years of age, there's a 100% failure rate. So whether we may not know who are the good patients for using it, we know the patient in whom we should not use it. This is an example of one of our own patients treated with the cephalomedullary nail for a fracture neck of femur. Now, the latest kit on the block is the femoral neck system, and that is actually a new system. The biomechanical evaluation has been done and published, and it shows that whether you are using a sliding hip screw with a blade or with the screw, or you are using the cannulated screws, this provides a valid alternative, and it has got advantages of being minimally invasive and gives good stability. So this is one of our own patients who you can see the intraoperative pictures. You can see the the gap at the fracture site. And the best thing about this system is when you start compressing, you can actually see the fracture gap closing, and it gives you 20 millimeter of controlled collapse with a derotation screw here and a device which allows controlled collapse here and a single screw here. We have the only one available with a single screw in India, though I suppose there are ones with double screws also, and this is the post-operative film. There is the disadvantages. There's very limited literature available for this. This particular registry was supposed to have been completed by July, I'm sure, because of the pandemic. This 12-month period of recruiting 125 participants, I doubt whether it has been done. And this has been compiled by one of my colleagues here, who has actually summarized the advantages and disadvantages of all. The cannulated screws have higher failure rate, and they do not have a controlled collapse, and they are biomechanically inferior, though they have the advantage of being minimally invasive, easy to use, and economical. The DHS with anti-rotation screw is stable, preferred in Powell 3, less failures, but then has increased operative time and the blood loss, and then there's a risk of femoral head rotation when inserting the lag screw, and there's a certain risk of avascular necrosis. The femoral neck system has got the disadvantage of cost, availability, and not much literature being available. However, it does have advantages of small incision surgery, less blood loss, less operative time. It's mechanically comparable to DHS, and then it does not displace the undisplaced fracture. To summarize, the young patient with undisplaced fractures, we prefer the fixation. The CCS and DHS are the most common methods of fixation. DHS is biomechanically superior. Clinically, they have similar outcomes, but have higher increased blood loss and higher AVN with DHS. Smokers, basic cervical and displaced DHS might be better option. And then, of course, you should operate within 48 hours. Inverted triangle configuration is the best. In smaller or patients or females, you can use one of the top screws as 4.5. The diamond, quadrangular, Powell screw, and posteriorly fully threaded screws have their advantages in particular situation, and Powell type 3 needs special consideration. I thank you very much for your attention. So now we are on to the case presentation, and I would like to request Dr. Vikas Agashe to present his case. In the interest of time, I would request the participants to be quick. Dr. Vikas?
Yeah, sure.
The stage is yours.
Thank you. Thank you. A relatively simple case as compared to the real complex cases that were discussed. So this is a Scottish man presented with non-union of intertrochanteric. You can see at the greater trochanter here, there's a big gap and non-union of the shaft. You can see there's a significant varus and anterior defect at the non-union. No comorbidities, a bit obese person, no evidence of infection, and he has been walking non-weight bearing. So here we have a non-union of intertrochanteric following an implant with a varus and an anterior gap. So may I invite suggestions? May I invite suggestions, Dr. Vivek, Paul, and Dr. Mir, and Dr. Malhotra? Any suggestions?
Yeah, so I would revise this with, I would re-nail it, but I would do an open nailing. I would do a cephalomedullary nail, and I would harvest bone graft at the same time and utilize bone graft. And certainly at the shaft fracture, the consideration could be to revise to also with a retrograde nail and then a dynamic hip screw and anti-rotation screw and treat them as two separate injuries, which possibly could have been done on the index procedure. Right. But I think one of those two constructs would be my choice.
So how far out is this now?
It's about 8 months after injury.
Out 8 months. Yeah. So the problem here is that there was nailed in varus, right? So I think you've got to not just look at the femoral shaft here, because the femoral shaft is easy, right? You work it up for infection, maybe it aspirate if you have concerns. I would definitely do a metabolic workup because femoral shafts generally do heal unless their vitamin D is very low. So I typically replace their vitamin D as well. Although there's, the jury is out on whether that matters, but I don't think it can possibly hurt. But I think the real question here is, do you want to solve the femoral shaft injury in isolation, or do you want to combine that with a VIT and realign the proximal segment? Because this is not going to be a good hip over time with that much varus displacement. So I would actually talk to the patient about it. I think the patients have a lot to say about their own care. I would explain that I think we need to correct that varus displacement at the femoral neck. We could either get the shaft solved and come back and do that, or theoretically you could do a VIT with a proximal locked plate and extend that plate down with a graft over the shaft and do it all with one procedure. But I think you've got to deal with both problems, and I would definitely work up infection.
Correct. Yeah. Vivek?
Yeah, the same thing. The only thing is, at this time, I might not go in for a DF. What I'm worried about is that short segment in the proximal fragment, which may not give me the best fixation for a DFN if I am going to use any of my angle blade plate or a proximal locking plate for my reduction and correction with VIT of the proximal neck fracture. So the plate and the screw, I might go in with a VIT and going with a longer plate for that, and that is going in the same sitting. That's my way of doing.
Right. Dr. Malhotra?
Yeah, I'm sorry, I'm missing part of the discussion. There are some urgent messages from the
No,
COVID ICU.
Right.
Please carry on.
Okay, sure. So, of course, the challenges were virus, bone loss. Obviously, there's bound to be fibrous tissue at the non-union site and avascular bone. And of course, we have an ipsilateral femur. So, obviously, one needs to remove the implant, excise the sclerotic bone and fibrous tissue, and we need to realign, fix, and graft. The question was, do we do an angulation correction osteotomy, and whether we use a single implant or a double implant or replace. So whether we do use a DHS with a bone graft, or whether we put a 95-degree and correct it, and whether if we use two different implants, then as discussed, whether we do a distal femoral nail and a plate. So we basically decided to use a single implant, a Cyrus nail with 3 screws proximally with 1 miss a nail technique, 1 screw at the subtrochanteric level, and 3 distal screws. But something which was very, very important, and this was a 2010 paper in ISAO about primary non-union of intertrochanteric fracture and valgusization, and tips about excision of fibrous tissue and realignment. We were always thinking how to realign this proximal fragment. So the paper mentions that the clearance is generally done superiorly, anteriorly, and inferiorly. Obviously, you can't go posteriorly, and a common pitfall follows. The defect is often closed by internal rotation to get a good bone-to-bone contact. Obviously, one needs to have a good bone-to-bone contact. And then there is an excessive anteversion. And then the guide wire would be unacceptable in a lateral view. So I've just shown this on this picture. If there is a defect, very often the defect is closed by internal rotation, but which would lead to excessive anteversion. So instead, graft should be put in this space, and then one can fix. So what we proceeded with that, you can see we did a lateral exposure on fracture table. We explored the fracture site or non-union site, removed the implants, and then used 2 thin osteotomes to excise. Rather than going at the fracture site, we used 2 thin osteotomes and just excise the sclerotic bone with the fibrous tissue in toto. Then put 2 K wires here to derotate the head and keep it in appropriate position of valgus and an appropriate anteversion. Then put grafts here and put a 12mm Cyrus nail with a pisser nail proximally, and of course ream the distal part and put a graft there. This is post-op X-ray. This is with correct anteversion. At 4 months, we thought that the femur was going into delayed union, so we took out the subtrochanteric screw. This is at 6 months, healed quite well. This is at 10 months, and this is at 4 years. Absolute excellent function. So to recapitulate, closing the gap is to be avoided. Avoid anteversion. So most important is angulation correction is very, very important. It is a challenging situation in young patients. Of course, we need to preserve the head, and as I said, angulation correction is the vital thing as far as non-union of proximal femur is concerned. A very nice algorithm is described in this article about failed intertrochanteric fractures. What factors determine the failure? This is 2020 recent paper where they consider whether what is the condition of the femoral head. If it is destroyed, obviously we need to do arthroplasty. If the physiological activity is good, then of course we need to do a total hip, low demand hemiarthroplasty. If the head is saved, if there's a deformity, one needs to do an osteotomy. If the deformity can be corrected or there is no deformity, if the inferior portion of the head is intact, then one does a 95 degrees DHS angle blade plate to derotate, or if it is superior, then a 95 degrees angle bleed plate. So this is a very nice algorithm for non-union intertrochanteric fractures or a failed intertrochanteric fractures described in 2020. A very nice article. Please read this article. Thank you, friends.
Thank you, Dr. Vikas. We have a large series of managing the failed intertrochanteric fracture fixation with dynamic hip screw. And, while we create a valgus, we have been putting the fibula in the track of the leg screw and then using a condylar blade plate, 95 degree condylar blade plate. Still very fond of it. Actually, we don't need the compression you need, and it actually compromises very little bone, and that I have found to be very, very useful. Anybody would make any other comments related to Dr. Vikas's presentation? Hassan?
No, I like to treat all of mine proximal femur non-unions with revision nailing. It's just I like to allow immediate weight bearing, and I don't always feel confident with that with the blade. Also, I'm from the generation that doesn't do many blades, and so nailing is much more familiar to me. It's easy, it's not as technically challenging, and it allows immediate weight bearing and have pretty good success with union.
I'm from that older generation. My boss used to do a lot of. In fact, I love this implant. It's a great implant. It doesn't compromise any bone. Thank you very much. We come to the last presentation of this track, and I would request Dr. Hassan Mee to present case on proximal femoral fracture. Dr. Hassan, please.
Okay, so. This is a 71-year-old woman who's actually an Indian lady who lives here in Tampa, but was vacationing in Morocco with her husband and was in one of the little markets and fell and broke her hip. And then she tells the story of how she was put in a cart pulled by a donkey and taken to the local hospital there and had this fixation done in Morocco. And this was 8 months before I met her. Then she came back to Florida and wasn't doing so well, and found somebody at another hospital who decided, well, your problem is that you need stem cells. So took her to the operating room and made her pay several $1,000s in cash and injected stem cells, but somehow they didn't work. And so now she presents to our clinic and is having significant pain with ambulation. She's using a walker. Before, this very healthy, fit lady, they're recently retired, they're traveling the world, but now is, in significant pain. Really minimal past medical history. She did have osteoporosis in the past and had been on long-term bisphosphonates, but in the few months before I met her, had gone to an endocrinologist and had switched to denosumab, which is not a bisphosphonate, but is an anti-resorptive drug for osteoporosis as well. So on exam in clinic, she's got a 1 centimeter limb length discrepancy and about a 25 degree rotational deformity. And you can see that, she's in varus there. So she has the typical deformities you would expect with a subtrochanteric fracture, with the proximal segment flexed in varus and malrotated. And it was just kind of nailed in situ there. So I'd like to hear from the group what they would do with this patient now.
Yeah, can I?
Okay. Yeah, you.
Yeah. So the varus needs to be corrected. Rotation needs to be corrected. There's bound to be a sclerotic bone there which needs to come out, which would obviously lead to defect. I would personally use a combination of a nail as well as plate. I'll put a nail it is quite likely that my nail will keep straying on the tract of the previous nail, and therefore I'll have to use allografts or some grafts to block that hole and take a little medial entry, so I have a valgus there. I'll possibly use Cyrus nail so that I can have 3 screws, and then I'll, in addition to grafts, I will put a plate.
If I'll go with a classical, I'm an old-fashioned surgeon. For me, this is an ideal case for doing an angle blade plate. You have varus, you have already the osteotomy which has been done for you. If required, it's a recalcitrant non-union because it's a atypical sort of a fracture. If it is, I might go in, I use a tensioning device in the lower part to give me the tensioning and the compression which I want. The rotational element I can easily correct when I have opened up that fracture site. And if required, there are papers which suggest that I can use a small plate on the interior side if I require to get an additional fixation, which may not be there in a 71-year-old lady. With an angle blade plate, I might add a small plate on the interior femur with a bone graft while doing an osteotomy.
That's interesting. It's close to what I would do. So it's an atypical femur fracture that you can see that beaking, and I'm assuming that when you do full length films, that correcting the varus into valgus will get your length back, and Hassan will tell us if that's incorrect because you do that assessment, of course. But these are ones that are that are almost non-unions when they start, right? Because they have such poor osteoclastic function. So I would take this all down. I would actually burr the ends off and potentially even do flat osteotomy at the edge. And then I would crank it down with 2 screws on the lateral side to really correct the valgus. I usually put a small, like 3/5 anterior plate on to hold it in place, because I find that it's very hard. There's so many dimensions of freedom. I find it difficult to control everything with just clamp. So you compress it laterally, put an anterior plate on to hold it. Then I would use one of the newer locked plates rather than a blade, I think, for this. But one of those 2 options, and then really compress it on the lateral side. Like just compress it until that screw is about to fall out. And before you do that, you just got to loosen up the screws on one side of the plate. And then I may replace those anterior plate screws at an angle, or just take them off depending on the fixation. I would probably add some sort of RHBMP2 or something with graft to what will be an anterior defect after you burr it out. But I think you want maximal compression for, it's an atrophic non-union with poor response. So I don't love nailing these. I think it's perfectly reasonable to do it, but I've just had really such good success with maximal compression in these that I wouldn't change unless someone showed me somehow there was clear evidence to the contrary.
So let me give you another different way. I mean, I'm also old-fashioned, only a few years senior to Vivek. But I think in all such cases where there's an issue about healing potential of the bone, we have actually published it in Humerus, but I would always like to take out the nail and push a fibula down the same track. So I have the biological material traversing, but before that, of course, I will freshen the bone ends, correct the varus, push a fibula down, have it traversing the fracture site, and put a condylar blade plate and put a old-fashioned Mueller compression device to get as much compression as I can, and then put bone grafts around it and then fix it. Again, I heard Paul say that he would use a locking plate. That's fine. I mean, if I could get a condylar blade plate with locking screws, even better. But then this is how I'll proceed, which I suppose is another way of doing the thing. But I am always more comfortable if I have bone in both the fragments, and that's where our experience of using fibula intramedullary works very well, which would push me to use only an extramedullary implant and not an intermedullary, because I want a fibula in there, securing the fracture, going across the fracture site and putting the grafts from outside.
So you're doing a nail plate combo, but with a fibular allograft strut as your nail.
Absolutely. Not allograft, actually autograft, but then it's easier to get patient's own fibula than to get an allograft. Although I have a bank, but then, yeah.
Got it. Okay. So I'll show you what we did here. So I decided to re-nail it. I like compression, but I don't think nailing and compression go against each other per se. So I always like to measure the contralateral limb. So that shows you her 1 centimeter discrepancy. She's 39 centimeters on the right, 38 on the left. This also gives you the lesser troch profile for rotation, which I don't think is as accurate as what I'll show next, which is looking at femoral neck version on the lateral. And then obviously your varus valgus neck shaft angle you can compare here. This is looking at the lateral. You can see that her anteversion is off by at least 25 degrees there. And so that's our planning. And then here we opened it, took down the non-union, and then use a reamer irrigator aspirator to harvest autograft from the ipsilateral femur. And got a decent amount of bone. Anytime I use this though, I always mix it with cancellous chips, just because in early cases when I used this and didn't have any chips, not for volume of graft, but just I've found that it consolidates better when you mix it with some allograft chips as well. Next, this is me getting compression drill. I do agree completely with taking down the atrophic area of bone and drilling it in multiple fragments. I used a blocking wire to help with alignment, in addition to a lateral clamp to help gain compression at the fracture site. And then this was our final length, which we got back within a few millimeters, and our final rotation, which we got back within a few degrees. So that's what we did. Here she was at 1 year, healed, walking, back to all activities. You know, one thing I definitely agree with, trying to start with a more medial start point on the revision nailing. We did, but it was challenging to keep it there. So I also do nail plate combos, but in this case with just the blocking wire, we were able to get it realigned. So I didn't have to put a plate anteromedially. The other thing in these bisphosphonate fractures is, you know, the contralateral limb. So during the course of her treatment, she did start to develop, I think psychologically, a little bit of thigh pain, because I told her of the risk of the other side. So we got an MRI of the other side, didn't show any spots that were lighting up. And finally she calmed down and we ended up not prophylactically nailing the other side, but certainly a discussion with these patients is the other limb.
Hey, son, I see you did a static lock distally. Why not a dynamic lock distally?
So that's a big thing that our chairman here, Dr. Sanders, harps on. So if I'm worried about not having the fracture clicked in and compressed, I would lock it dynamically. But on her, I had it. I was staring at it. It's compressed, and I'm bone grafting it, so I locked it statically.
And do you guys, does anybody else use PTH for these?
Yes, of course. I wanted to say that would be an absolutely mandatory part of treatment, because many times as orthopedic surgeons, we forget that in fact the case which Dr. Vikas showed had intertrochanteric fracture and then had it on the other side. I was tempted to ask whether any treatment was given after the first intertrochanteric or not, because it is on us, you know, if she comes back with the opposite side fracture and she has not been treated on fracture. This and other thing which we get sometimes, which I have observed, is high diabetics who have very high HbA1c and highly uncontrolled diabetes. We have often found that their PTH levels are quite low, 10 or 12, and they often go into non-union, much like, you know, you hear the atypical fractures occurring in patients who have not had bisphosphonates. And in those cases also PTH really works. So in a case like this, I would have certainly done a PTH assessment to know that it's not hypodynamic or adynamic bone, although classically seen in the renal transplant patients. But in all such cases, I do like to see the levels of PTH and then supplement PTH.
Yeah, so I forgot to mention she was switched to PTH early on. And then the other thing to mention is that when I treat these acutely, for me, a lot of these are an open reduction, so I can drill the fracture site and treat it like a non-union case on the initial case.
Great.
So are we over time? I had another case, but if not, I can stop. It's fine.
I think we are okay with the case. Please go ahead. I'm sure the audiences love it. We can make it quick, but let's not miss out on that opportunity.
Oh, so you want me to show it then?
Please.
Okay. All right. Are you seeing the screen again?
Yep.
Okay.
Yeah.
All right. Okay. So case 2. So this is a lady.
You're in presentation mode though, so that we see like the next slide.
Next
and this
slide also.
Hold on. Hold on.
Go to regular slideshow.
Sorry. All right. Let me try it one more time. All right. Better?
Yeah, perfect.
All right, so this is a 72-year-old patient who was vacationing in Mexico, in Cancun, and for Christmas with her family, and fell and broke her hip and was taken to a local hospital there where she had this fixation done, and then came back to Tampa for follow-up. So she's 3 weeks out. She has severe pain with ambulation, using a walker. Previously relatively healthy. She had a distant history of a deep venous thrombosis and is on a direct oral anticoagulant pill for that. She also had a previous history of long-term bisphosphonate use that was stopped by her primary care physician years ago. And she presents with severe pain, a 2-centimeter leg length discrepancy, and a 30-degree rotational deformity. And this is her imaging. So comments is this. She's only 3 weeks out from surgery, and wounds look okay, no signs of infection, etc. So thoughts?
Yeah, I mean that's going to fail. Like, you know, I'm really conservative when people come in with stuff that doesn't look perfect. People get sent in all the time for this isn't healing on X-ray, and I tend to watch things for a long time. But this is not that case. So, you know, this is malaligned. It's invarus. It's often rotation, and it's short. So this one, unfortunately, is one that's going to need an acute reconstruction. And I would take it down at 3 weeks. You're going to be able to get an anatomic reduction probably just by doing it open, and I would get clamps on it, and I would nail it.
I'm sure you're not going to put that long a plate. So what about all these stress risers? You know, just leave them to pray.
Yeah, but I would do a long nail, so it just bypasses all of that.
I
Exactly.
think that's
Same.
the absolute indication for nail.
Yeah, same.
Same.
All right, good. We have consensus. First case of the day
Not a
with consensus. So that was my plan as well. Again, just similar to the last case, planning with length, alignment, and rotation of the uninjured limb. And then here this was after simply just taking off the prior implant and having her on a traction table now. It aligned well. And then just proceeded with nailing and, got her length, alignment, and rotation equal to the other side. And here she was at 1 year healed. So
That just means it was too simple a case if you couldn't get us to disagree, you know. You gotta...
No, that's why I showed it second, and I was gonna just stop, but it's the first case of the day with universal international consensus. How
There
about
you
that?
But Paul, I don't agree with you that the simple cases don't lead to dissent. I mean, knowing orthopedic surgeons, I don't believe that at all. Simple things don't deter them from arguing.
That's a valid point. That's a valid point.
So thanks a lot, gentlemen. It has been a great track. I'm really appreciative of the efforts you put in. Before we wind up, we have to be fair to the people who have asked questions. Just quick questions. Paul, there's a question for you. For your case, would you have considered infix? So your thoughts on infix?
Yeah, so I've used infix, I don't know, maybe 12, 15 times. I have a couple of cases where I've used it in isolation. I'm not thrilled with it. You know, I really loved the idea of it when it came out to avoid the anterior frames and keep out of people's way. It is a little bit hard to place because you've got to bend the ends of the rods at such a high degree to avoid the femoral nerve. And there's been a publication looking at femoral nerve impingement, and I haven't had that happen. And I would say that patients tend to tolerate it better than an X-Fix, but 100% of those patients get HO when you around those implants deep. I've only had one patient who's complained of it, but they all form it, and it's a little bit of a bigger deal to take it out. I've actually switched back to just doing anterior frames, you know, in the handover position and leaving them on for 6 to 8 weeks, and then just taking them out in the OR. It seems to be somewhat easier, and I didn't feel like the infix was such a huge advantage to the patients in whom I used it.
And then the difficulty of removing, like you said, is a big.
Yeah, it's a little harder to get out. You've got to watch the nerve. You know, you've got to do a real approach. You've got to excise all that HO. So I'm just not sure it's worth the convenience for the 8 weeks that it has to be there.
Sure. Paul, there are a couple of quick questions for you. The first one is, how do you ensure a medial entry point in a very obese patient? And second, your experience of using cement augmentation, and I presume it's PMMA augmentation of the screw for a proximal femoral fracture.
Well, so in really obese patients, you can do them lateral. I don't do a lot of that. I still mostly do them supine. But if you put the patient in a real C position, you can usually get that medial start point. If they're very, very heavy, doing them lateral is going to make it a lot easier, because as soon as you flex the hip, you can easily access. I mean, we used to do a ton of piriformis nails in that position, and it's not hard. So I think the more obese, the more you might want to go lateral. I have no experience with PMMA in the femoral head. I've never done that operation. I use the same implant that you saw Hassan use, which is it's sort of a double screw device. And I don't know that it matters what one you use, but having more than one fixation point in the head gives you that stronger rotational control, which is what I think you get out of the PMMA. And I haven't had that cut out as long as you put it in a good spot. I don't know if other people on the panel have experience with PMMA. I just haven't done that.
Dr. Hassan, would you like to supplement that answer?
Right. So I think that augmentation is an interesting concept, but to me, I don't know that PMMA is the right way to go. I think there are other substances coming out that may be better and that'll work with implants that might be more advantageous, because from my understanding, and correct me if I'm wrong, the PMMA that you're using is also exothermic. And so you're frying the inside of the head that you're trying to salvage and save. So that doesn't make sense to me. So if you can use something that's not exothermic and that also is more biologic and will remodel, then that makes a lot more sense if you're going to do augmentation with another material.
The other interesting thing is, you know, using the calcium phosphate concept, right, as Hassan was alluding to. But there is an international study. I don't know if any of you are involved, but it's called the RESTORE study that myself and a colleague from Italy are the co-PIs for this international trial, which I think is very interesting. I got involved. I'm not with the company or anything, but I got involved because I saw the early data on this, and it was pretty pretty convincing for something that I wouldn't have thought was a great idea, which is this is for the contralateral hip in patients who have femoral neck or intertrochanteric fractures, of burring out the inside and inserting a phosphate to have it then heal. And I you know, this has been talked about for 25 years. Like, this is the first time we had sulfates and phosphates, we were talking about this, and, you know, how do we deal with the other hip in these patients? And it was dramatic how much these things, the increase in bone quality that with the resorption that occurred, I was actually very surprised, enough so that I've now gotten involved with this study. So I think that there's going to be some stuff coming out around what you do for the other side of the hip. Can you prevent fracture? And using that same concept, you know, now that that's been, in my mind, pretty well shown, at least in a series of about 50 patients, that same concept as Hassan was alluding to, of using the phosphates around some of our devices now that actually may create more bone rather than just taking something out and providing a temporary thing that gets crushed or resorbed. So that may be something to look into in the future. I wouldn't do it today, but I think it's something that may be coming down the pipe.
And Dr. Hassan, what about BMP? Paul mentioned in the discussion. Do you use it very often? Because, you know, we have very limited exposure to that. One, it is prohibitively expensive. And we have had a couple of patients throw up a very vicious allergic reaction, almost needing transfer to ICU following the BMP. So what's your experience with the BMP?
Yeah, so 10 or 12 years ago, I used it more often. The last 5 years, I can't remember the last, I haven't used it at all. So I use a lot of autograft. And then if I want to supplement it, I'll go more towards a cellular product or something, but I don't use BMP anymore.
I still use it on occasion. You know, when I use it is for, like, the last time I used it was a couple of weeks ago. We had a patient with a legitimate 3C injury who had a bypass from their popliteal to their perineal, to their posterior tibial perineal trunk, and lost their entire anterolateral compartment. I honestly think it's going to end up with an amputation. And we did a fibulectomy along that entire area to allow closure of sort of the posterior column to a medial gastroc flap around the front. So I'm not sure it's going to be salvageable, and there was a big defect that is going to be difficult to get back to. So situations like that where I don't want to use graft, I want to do something to maybe give ourselves one good shot. I think that's sort of the ideal circumstance for RHBMP2. So it's time when I wouldn't want to sacrifice someone's own bone, and I want to just give myself some help. So things like that, I think, are good indications, because it does form bone. Although it is expensive. So it's you know, we use it once or twice a year probably.
So this was in an acute fracture setting, right? Not a delayed union or non-union.
Yeah, I generally don't use it in delayed and non-union. I prefer autograft, and that's what I've used for my whole career. I'm not a big BMP user for those.
Great. Any other closing editorial comments, remarks? Well, if not, I must thank you, gentlemen. We have actually kept you engaged for half an hour extra, and that's the testimony to the fact that it has been very engaging interaction. I have learned a lot, and I'm sure all of us had this great opportunity to interact with each other, and we had some exciting cases. Once again, I appreciate your participation, your time, and I want to thank Insignia for giving me this opportunity to sort of pilot this track. And once again, I think it's a great session because we have had great faculty. Thank you very much, and have a great day for those in US, and have a great evening in India. Bye-bye.
Thanks so much for having me.
Thank you.
Listen, guys, be safe, okay?
Thank you.
Best
Thank
wishes.
you.
Bye. Bye. Bye.
Bye.